Bore da, croeso I gyfarfod I both Haldar. Good morning and welcome to the Haldar board meeting. So I'm going to start with apologies, and we've received apologies from Donna Coleman, the Regional Director of CLICE, that we have Helen Williams, who is attending in her place. And I'm also pleased to welcome Sharon Daniels, who is attending this meeting as well. I know that one of our IMs, Michael Prato, will be slightly late joining the meeting because he's travelling quite a distance today. But those are the only apologies that I've received. So if we can move on to the agenda, and if I can ask for any declarations of interest.
Whisk for me, just in case, other than my name.
Thank you.
Distribution, just in case.
Okay, thank you. And I'd like to declare an interest in any items referencing the Regional Partnership Board, because that's a board that I also chair. Okay, thank you very much. So if we move on to the start of the agenda, and the first part is the minutes from the extraordinary public meeting held on the 14th of September. Are there any items that anyone wants to raise, or any corrections to those minutes? No? Okay, so we agree those as a correct record. Thank you. Then we have the minutes of the meeting held on the 28th of September. Are there any items, issues anyone wants to raise on those minutes? No? Thank you. And then finally, we have the minutes of the annual general meeting held on the 28th of September. Again, any items to raise on those? No? Okay, thank you very much. So if we can move to item 2.4, where we have got the combined table of actions. So I'll go through them page by page. Is there anything anyone wants to raise on page 1? Okay, I have an item on that page actually, and it's in relation to PM 23124. The Memorandum of Understanding, I wonder if we have a date at all.
Chair, no, we don't have a date at this point in time. It's being escalated through IEG, and we're waiting on our local authority partners to respond. So don't have a date for you now, but we'll endeavour to get a date before the next meeting, because it has been quite some time now.
Yeah. Okay, thank you very much. Anything on page 2? Anyone has?
So if I may, it's PM 23181, and it's in relation to my favourite topic around vending machines and drinks and beverages within A&E. I was advised last week that the beverage machine should be arriving this week. So I plan, as part of my review visits that I'm undertaking across the sites, to check that they've actually been delivered and installed. Certainly the quality of the drinks vending machine that's been placed in Havendoo, and if it's of that calibre, then that should be a positive step forward.
Okay, thank you very much. Anything on page 3, the table of actions?
Yes.
Yeah, on the same minute, PM 23181, the last point, the Children and Young People's Group, who they report into, it's the response says it's an operational group within the Executive Director of Operations. Outputs are reported to the relevant assurance committee of the board. Just wondering, what is the relevant assurance committee, or will that vary depending on the topic?
Andrew,
I'll have a go, Joe can help me. I think, as you said, you sort of got there, Maynard. I think it's going to be around the nature of the topic and which is the most relevant assurance committee. I know, for example, because it was putting together a range of things across the organisation, there's a number of things that have already considered a CRESEC, for example. So, yeah, it will be around what's appropriate in terms of the issues.
Can I respond to that as well? As you know, I'm the Children and Young People's champion, and I sit on that operational group as well. And there are recommendations that I give to that group as to which relevant committees are best suited for discussions.
That's helpful, thank you very much. Is that okay?
Yeah, that's
Yep,
fine, thanks, Chair.
thank you. And then anything on the item on page 4? Okay, thanks, thank you very much. So we'll move on to the Chair's report and item 2.5. This contains items which relate to the time before Maria Battle retired and also some things that I have undertaken as interim chair. I'd just like to highlight a few issues. On page 1, I just want to reiterate the board's condolences to the families, those members of staff who sadly have died, and the details are there on pages 1 and 2. On page 3 through to 5, actually, there's an amazing array of awards that have occurred both internally and externally, some on a Wales level and some on a national level. And I think it's just remarkable. And huge congratulations to all those staff who've been successful in those awards. It really is great to see. Finally, on page 6, right at the end, I do want to again pay tribute to Maria, who, as you know, has retired and gone on to do better things, different things. So I think we do want to wish her best in her retirement, and there's some more details there. What I am able to say is that we have now had confirmation that Eleanor Marks has been appointed as the Vice Chair of the Health Board, and she takes up her post from February. And I'm absolutely delighted that Rodri Evans has agreed to help by being the interim Vice Chair until such time as Eleanor starts. So, Rodri, thank you very much. I don't have any more information about the appointment of the Chair other than what's stated in the report. So that's all I wanted to say. Has anybody got any questions or anything you'd like to raise on the paper?
Thank you. I'd just like to formally congratulate the maternity services teams in Bronglais and overall for their safety award as well. I just think it just illustrates the good practice that we've got in Hywel Dda, especially with the highlight on maternity services nationally. And I think we all need to congratulate each and every one single member of that team for that.
Thank you, Helen. And then, before we move on, I would also like to say, in case you thought I'd forgotten, that this is Mandy Rayani's last meeting as our Director of Nursing Quality. I'm not going to try not to make her cry, but there will be opportunities, obviously, to say goodbye to Mandy. We've already had one event, but she has made an amazing contribution to the Health Board, and we're all incredibly grateful and going to miss her. So good luck in your retirement, and thank you, Mandy. See, you're almost crying.
Yeah.
Okay, so if there are no more questions, I'll move us on to the Chief Executive's report.
Thank you, Chair, and I'll pick up where you left off, really, and I'm going to try and make her cry. Just to record, as this is a public meeting, I think the sincere thanks of myself personally, and I think probably on behalf of the whole board, for everything you've done since you've been here, Mandy. You've put quality and safety at the heart of our thinking. You changed the culture, I think, out in the organisation, and that's no mean feat. And I think the improvement methodology, the focus on allowing the organisation to have that continuous improvement is going to be a long-standing legacy for you. Personally, I'm going to miss your laugh, because I always know where the exec team is. But it's been such a joy working with you for all these years, and it's always slightly bittersweet. It's not good retirement, and you should look at it with some pride. But I know the whole exec team, indeed the whole board, is just going to miss you hugely. So thank you for everything you've done. If I can also then move on to a new beginning. We have our new Director of Therapies and Health Sciences starting with us. So this is James's first meeting. I have to say, in a very good way, he's already become like a bit of the furniture. And that he's had a really strong impact, both this sort of energy and enthusiasm, and maybe the replacement laugh, I don't know. We certainly do, but got a really full agenda ahead of him, and I'm looking forward to seeing what James can do to help us move that really important part of our service forward. So welcome, James, to your first board meeting. On more day-to-day business, you'll see in the report I've covered the latest TI quarterly meeting that we had with Welsh Government, and also just gave a very brief update on the Joint Executive Team meeting, the JET meeting that we had with Welsh Government, which at the time we weren't able to put in the report. Just to follow up on that, we will provide a report through the normal channels and ARAC on both of those issues in due course. Overall, I think a realistic, positive in some ways, tone from Welsh Government on the things that we have done. I think the key challenges that they put back to us, which won't be a surprise to the board, particularly in our discussion at JET, which is a half-year review of our position, was firstly around the financial situation that we face, and the board will be very aware of both the scale of that challenge and also what we're doing to try and address that both this year and going into next year. The second was around the real importance of our clinical services plan, around how we're going to ensure that we can maintain services during the intervening years between now and the realisation of our Healthier Mid and West Wales strategy. And then the third was a discussion, and there have been follow-up discussions since this, around regional working and the desire to ensure that we work together very effectively with our partners to deal with some of the biggest waiting times challenges that we have. So none of that, I think, unexpected for us, but I think reasonable challenge and things that we are very much focused on as an exec team. And then finally, I just wanted to highlight the issues around the Sexual Assault Referral Service that we have in the paper. Quite a number of years of work in that, some of which was delayed through the pandemic, but a real sense that things are moving forward now. To clarify the money and just to ensure the board is clear, we have put aside in our plans the money that was expected, and this is within that expected money. The numbers quoted are for the regional part of that plan, and you can see within that number and within the recommendation the amount that falls due to this health board on its own. So I'm seeking some approvals around that today. Other than that, I have to take questions.
Okay, thank you. Questions? Maynard.
On the SAC, the paper asks for approval of £347,000 contribution this year. Is that, by reading of the actual SAC paper, is that the all Wales figure?
That's the regional figure for our part of Wales. And so it's not national and it's not local. It covers us Swansea Bay and the bit into Powys that we cover.
So how much of that is actually health boards?
The 130. So that's our proportion of that regional figure.
Okay. Thank you.
Okay, thank you. Any more questions? No? Okay. So the recommendations are there on page 5. I'm not going to read them all out, but are the board content to approve those recommendations as listed? Yes? Okay, thank you very much. Thank you, Steve. So we'll now move on to 2.7, which is the report from ARAC. Roderick.
Thank you, Chair. As you can see, I'm not going to go through it, but the report summarises work of ARAC at its meeting on the 17th of October. And you can see all the work that we've gone through. And we, as I always say, in this committee, we really scrutinise and we look at things in detail. If we're not happy with something, it comes back. And so if you can see, I take it as read. If you look at the page at the end where it says a couple of things. Firstly, matters requiring board level consideration or approval. Well, there's 2 on the next paper is going to be coming up now. The revised standing orders and standing financial instructions and the changes to the scheme delegation. But if we turn a page then and we look at the concerns, issues, matters of concern, there were 2 findings, concerns in relation to the findings of quality and safety governance at Bronglais Hospital, limited assurance from internal audit, and there'll be a follow-up audit conducted ideally in time to report to the next meeting, hopefully now in December, and also the findings of the NICE guidance, also limited assurance. A follow-up audit will be conducted by the end of the year. Therefore, I know it's brief, but I take the papers read, and if there are any questions, then.
Okay. Any questions? No, just, Anna, sorry, first time.
Chair, thank you, and my apologies for being a minute late this morning. I wonder if I could just ask exec colleagues to elaborate a little further on the action being taken around the limited assurance in quality and safety governance at Bronglice, please.
So if I may start, just to confirm that there have been some further conversations and clarification about the requirements that were set out some time ago around the use of standardised templates and reporting arrangements. And I've had assurance that that has now been deployed into operational practice. And Sharon actually has been up to Bronglice as well to have some personal conversations with individuals to make clear the expectations around quality governance. So the formality of the meetings have been stepped up. So I do expect to see some improvement. And yesterday, I believe it was internal audit, confirmed that the further follow-up will be coming back to ARAC in February. So, but we have an interim arrangement.
Andrew wants to add anything.
No, I think you've probably said as well for you.
Chantal, is your question on the same thing?
No.
Can I just bring Jo in?
Yeah, just to add to what Mandy said, from an assurance perspective, internal audit have already followed up the actions which had a very close implementation date, and they will be coming back alongside the team from Bronglice to the December meeting. But what we want to do is to ensure that those recommendations have been fully embedded. So before the end of the financial year, there'll be a further more detailed review, not to go back to each recommendation, to ensure provide assurance to the audit committee that they have been implemented and embedded, because the committee were very concerned. So we asked for a two-stage approach to the follow-up, Chair.
Okay, thank you very much. Thank you. Chantal.
Thank you, Chair. It's in relation to declaration of liberty safeguards. I know that there is reasonable assurance, but because of some issues with the wording, then that is going to be reported at the next meeting. I'm just wondering what were the issues around the wording of certain aspects of the recommendations?
Right. Do you want me to cover that? Yes, it was actually very, very simple, but due to the appropriate process in terms of ARAC, any question really in terms of what's presented in that committee does need to go back and be checked and then go back to further committee. So what internal audit had done was to use the same wording for each of the recommendations against which we made a management response. And actually the wording that they had chosen for the first one didn't quite match the action that they were seeking. So it was really just a technical issue in terms of clarifying that. We've already had the meeting, we've undertaken that, and the report is ready for the next meeting to be formally accepted.
We have also reviewed the sign-up process as well for internal audit, because it did put the audit committee in a difficult position in terms of being able to accept the reports. We reviewed how reports are signed off, and as Jill says, that Jill and I have met with internal audit and clarified the wording. It was minor. It will be back to the December committee, Chair.
Okay, thank you very much.
I don't apologise for the scrutiny we put into these papers, because we need that assurance, and that's why if we're not happy, they do come back to the next meeting or whenever that information is there. So I think we are doing our work, and we are scrutinising our papers. So thanks for those questions.
Thank you. So we have the two items to approve. The first one is the revised model standing orders and the standing financial instructions. We're happy to approve those. Yes, thank you. And the revised scheme of delegation. Yes, thank you very much. So if we can move on to item 2.8, which is the quality, safety and experience. Can I see it?
Thank you, Chair. And if I can also start, please, by recognising Mandy's last meeting and to offer formal thanks on behalf of the committee Mandy, for your exceptional work. I think it's safe to say that the committee you leave behind is in a very different position to the one that you inherited. From a personal point of view, I've always been immensely grateful for your support as my executive opposite number through this committee, and will miss you enormously. So thank you very much indeed. Moving on then to the report, the content of the report stands. I'll just pick out a couple of things. In that same vein of continuous improvement, we have held our workshop to look at our self-assessment process. So that's now has happened, and with colleagues I'll be looking at the outputs from that session and thinking about how we're building some ongoing improvement into the way we operate the committee, and that's been about increasing the level of scrutiny, self-scrutiny we apply to the operation of our board committees. I will just also mention, if I may, the patient story, a very powerful patient story at our last meeting. I think it affected all of us, and a number of next steps were clarified, and I have asked that the family of the patient concerned be kept informed of progress, and we're grateful to the family for being willing to share that very difficult experience with us. Couple more points to pull out. The pressure damage and falls. We look in every committee, we have a standard quality assurance report and look at a standard set of metrics, and pressure damage and falls are included within that. And the data as it's presented suggests we're not really making any movement, any improvement. And so we agreed at the last meeting it'd be helpful to try to get under the skin of those headline figures, and Mandy's team are taking forward some more work to really try to understand if there's any changes we need to make in the approaches the approach we're taking to try to improve pressure damage and falls across our organisation. And finally, given the report we've just received from ARAC in relation to operational governance, I will just highlight to the board the specific issue that was reported to our committee around low attendance at the OQuest meeting, which is the operational meeting that sits under our committee. But I think that is probably one of a number of sort of flags we've got around concerns to do with the robustness of the operational governance arrangements in the organisation, which won't be news to the board. We've discussed it in various places over recent months, and I know Andrew's got a number of actions in place related to structural changes as well in the operational services that should help that position. But we do, as a committee, rely on the scaffolding, as I describe it, of the operational governance system to allow us to do our work well. And so we really do want to see some improved confidence around operational governance over the coming months. I'm happy to take any questions. Thank you, Chair.
Thank you very much, Anna. Are there any questions? We've got Helen, Chantal.
On the savings plan, it says that you had a meeting with the health minister the following week and advised that it is important that public conversations are taking place. And I was wondering if the health board have started having those public conversations within the communities.
I think that was in, if I can respond, I think that was in specific relation to the risks, the opportunities that we need to take as an organisation to be able to find our way back to financial recovery, but also to ensure that the quality, safety, experience of our services remain in the best possible state that they could possibly be in, given the challenging times that we've got. We take every opportunity, I think it's fair to say, to engage with members of the public, whether that's through a consultation process about a changed or new model, new way of working, particularly thinking about the paediatric discussions that we'll be having later on the agenda, whether it's been about our strategic direction or whether actually it's in smaller service-defined groups through the public forums and engagement that we have. So, for example, I'll just use the maternity example and the engagement that we have with our mothers and their families. about their experiences of services and what people can expect. So I think there's more work for us to do in this space, if I'm perfectly honest. Doesn't mean to say it's a job done, but I think it is something that we just continuously need to do. And certainly at our last joint executive team meeting with Welsh Government, I think there is clear recognition that any of the decisions that we take as an individual organisation, or actually as organisations across Wales, it doesn't come without some considerable challenges for both the provider organisation, but also the population of Wales and their expectations and how we support engagement with services. So it's not a total, yes, we've done it and it's done. It's a work in progress that will continue.
Thanks, Mandy.
Thank you. Chantal.
Yes, thank you, Chair. I did note that there were a number of concerns that was raised as part and parcel of the committee. I'm just wondering, the kind of actions that would be undertaken in order to try to minimise those concerns.
Are you referring in the context, sorry, Chantal, in the context of the
well, one
engagement at operational level?
Yes.
Yeah. So just to provide some assurance, whilst, and I need to be clear that it was actually me that commissioned the internal audit for Bronglais, because I had some concerns about the robustness of the arrangements. And as we can see from the limited assurance report, my concerns were founded. I think that it's fair to say that the teams that we have in place at the moment are taking their responsibilities around quality safety extremely seriously, and they are meeting regularly. The area that we have some challenge over, and I have reminded and reinforced people of the expectation around attendance at the operational quality safety meeting, I've done that only this week again, is that they don't always present and escalate appropriately into that meeting so that they can share both the learning but also the risks that are being undertaken or being managed across the organisation. So there has been further reinforcement of that. I think with the work that Andrew's doing around the operational arrangements, that will enable us to further strengthen those links. What I would say is that the corporate quality assurance team are working extremely closely with each of the services and the directorates and the triumvirates. And whilst the heads of nursing across the entirety of the organisation hold the lead to facilitate, coordinate, etc., around quality safety patient experience, I've made it clear to all of the triumvirates that they each play the same part in the same way that we do as executive and clinical colleagues. So hopefully that will strengthen the position and reinforce it going forward.
Thank you very much.
Did you want to go and say
it was really just to mention that, but also around pressure damage and falls. We track, just to give assurance that we do understand the level of harm and impact that some of the patients are experiencing as a consequence of either pressure damage or falls. The majority of our reports currently are for those patients who are living in a community environment who are not known to services. So they're not having any community nursing services, they're not having necessary input from any providers. So we're capturing that at this moment in time. But if we think about the, and that's a piece of work we need to do in the community, specifically around falls and pressure damage. There is work going on, and particularly through the clinic processes that have been set up around lead clinics and everything else that will help with our tissue viability, knowledge, skills and experience. In terms of falls, only yesterday we were looking at an extension of a piece of work to support falls management in the community. We will be revisiting that because actually we need a consistent approach across our three counties. But there's also the work that we need to do strategically and on a multi-organisational basis around falls as well. Just as an added assurance, I suppose, certainly from an inpatient, in-hospital perspective, every ward sister and senior nurse speaks to me at least every 6 months, if not more frequently, as part of the Nurse Staffing Levels Wales Act calculations that we undertake, and we scrutinise as part of that exercise all of the incidents that are associated with nursing care in particular, and that includes falls, it includes medication errors, and it includes pressure damage plus one or two other harms as well. So the level of scrutiny that this receives is not inconsiderable. The level of harm that we've seen has reduced as a consequence of some of the initiatives that we've put in place as well. So I just wanted to reassure people.
Thank you. Anybody else has a question? Coming on to that, as a key risk is hand hygiene. Yes. And I'm really, really concerned that currently it's down to 32%. What is being done to address that? And when can we see an improvement? Because as we know, hospital-acquired infections lead to longer stays, deterioration in patients, etc., etc. So I'm really, really concerned, and I'd like to know what mitigations we have in place.
So if I start, and Phil may want to offer a comment, hopefully I'll address it. So as you're aware, we've got a significant programme of activity taking place within the organisation around infection prevention control. Hand hygiene, bare below the elbow, are two key components of that. So the 32%, and I will confess that there was quite a lot of conversation that took place behind the scenes as part of the development of the papers, both for Operational Quality Committee and then obviously subsequent reporting in here. 32% is not consistent across the organisation. We have pockets of what I would call, I won't call them excellent actually, because it's the standard that they should be delivering consistently, 90% plus. However, we do have some areas where we have consistent reluctance by key personnel to comply with bare below the elbow and also hand hygiene. I've taken that issue up with the appropriate executive leads and also sought some further support to be able to reinforce, regardless of the evidence that people may challenge around some of the practices. That's the policy and the standard that we expect within the organisation. So we've got a couple of campaigns that we're looking at reinvigorating, gloves off, hand hygiene being one of them. So that is something that the infection prevention control team are leading. But I'm confident that I've got the support now of my executive colleagues to help drive that one forward.
Thank you. Phil, do you want to add anything?
Mandy's given a really comprehensive update as always. I suppose I'd add that there are some areas where we've seen a significant improvement behind that 32%. So some of the actions we're taking, you can see behind the data that it does have an effect. And I know that we're tackling the areas which Mandy was alluding to, where there's resistance and reluctance because it's a professional responsibility.
So when could we see an improvement?
Well, when I first arrived here 6.5 years ago, hand hygiene was on the agenda, and despite best efforts, we've gone up and down, and it is a bit of a roller coaster. And I'm afraid I think it's going to be one of those things that we're going to have to constantly reinforce. So the areas that are demonstrating extremely good practice, so if you walk into Prince Philip Hospital, for example, or you walk into Withybush Hospital, as another example, if you don't have your elbows bare below the elbow and you aren't seen to be washing your hands and using appropriate gel, then you will be challenged by any member of staff. What I need is for that same tenacity to be rolled out. That doesn't mean to say we have got specific problems in Glangwili and Bronglais, but I want that consistency across the entirety of the organisation.
I wondered whether we've considered looking at implementing various objectives as part of the PDRs of those who are very reluctant, to comply with the various policies.
Yeah, we've operated, I won't say a 3 strikes and out, but we have implemented a process regardless of the profession that you are associated with or the role that you undertake. You have a conversation individually, you have a reminder conversation, there is not a third conversation, it is escalated. So whilst it is absolutely clear as part of the PADR process the revalidation and appraisal process for medical staff and other colleagues, it has to be built into that more robustly than perhaps it is at the moment. But that's part of the work in progress that we're undertaking. Lisa.
Just to comment on that, the PIDR process isn't the mechanism to deal with that. We should be tackling it as it happens, and in the moment there should be no surprises in a performance review because it's a much wider conversation.
I will just add, because this came up at the chairs meeting, because there were some Wales figures on this, and it was a conversation also with HIW about whether more need to be done in the education institutions to remind students as they're going through their training all the time that this is something that they must be aware of and they must comply with, so that they're not arriving from those institutions claiming not to know. And it defeats me because I've been at it longer as well. But still, so that is another element to try and tackle this.
Just to reply from the university, and obviously because I teach on all of the commission programs, and we do that. And indeed, they have to have those sessions before they go on to their clinical placements. But often it's how they are socialised onto the ward that is their problem.
Yeah, I think it's a number. I was going to say it's more than a two-pronged attack. It's multiple prongs to try and improve matters, but it is being closely monitored. Okay. No more questions for Anna? No? Okay, thank you very much. So we'll move on to what is quite a lengthy part of the agenda, but I don't make any apologies for that, and that's the paediatric services consultation. I just want to say a few things first before I hand over to Phil. This is a key part of the next stage of the clinical plan, and you'll see later on in the agenda it's referenced there. So how we're going to do this is that I am going to hand over to Phil, who's going to provide the choreography for this, which will bring in various colleagues, and welcome to colleagues from ORS and also colleagues from Paediatric Services. It's good to see you, and please if you can introduce yourselves when you're brought in. I would very much like the board to wait until we've been through all the information we're going to receive, the presentations, and then ask questions after that. I think because there is going to be a lot of conversation, I'm planning that when we have completed and everyone has asked everything and we have got to what seems to be a conclusion, I'm going to take a break so that I can make some notes to make sure that I do take us all through the recommendations which are on the main paper on page 18. So we're very clear on what decisions we've made, rather than try and sort of rush those at the end. So you will get a break when we've completed our discussions on this item. So I'm now going to hand over to Phil.
Thank you, Chair. So the understandably large bundle of papers are the culmination of 2 years' work from the team, so of course filled with information from our public and our staff. And in that paper, it's you can see there's the results of our public consultation. We're striving for the safest services for children in our area, and that's what all of this work is underpinned by. And we know that these services have been under significant focus for the best part of 10 years, and we know that there's significant public interest in these services. So we do have a presentation to help navigate us through the papers, and it is great, as you said, Chair, to have opinion research services with us, but also 2 of our consultant paediatricians and our paediatric services manager here, Nick. So yeah, as you say, I'm sure they will introduce themselves when we get to them. And just wanted lastly, just before I hand over to Lee Davis, our Director of Planning, just to say thank you to Fleiss, Helen from Fleiss, who I know has been supporting the process all the way through. So over to you, Lee.
Thank you, Phil, and I'll just share the slide just to make sure everyone can see it. Fine, great. Okay, so board members would be very well aware of the process we've been working on over the last period of time, as Phil has mentioned, which is concerning the delivery of urgent emergency paediatric services, particularly around Windrush and Bangor hospitals. Today, as a board, we're receiving the independent report from Opinion Research Services on the feedback that we've received through the consultation process. What we're asking board members is to consider that feedback today, alongside the reasons for the previous service changes, the options and the scoring of those options by the key stakeholders who developed those options previously. And we're also sharing with you the feedback that we've had from the stakeholders that reviewed the consultation findings, and then of course we also present the updated EQIAs as well as part of that consideration, and that will be an ongoing process. This has a extensive and detailed process, so as Phil mentions, there's alongside the SBAR there are 9 appendices which give quite a substantial amount of detail for board members to consider, which I know everyone will have taken the opportunity to have gone through that already. What we are going to do is take the next 15-20 minutes or so just to summarise the key points within that, and then move on to the questions and discussion. And Howard and Kester from ORS will take us through the consultation report shortly, and Marcus and Nick will be helping us with the options and the scoring of those options shortly. Just to reiterate Phil's point, I'd like to just thank on behalf of the board Nick, Marcus, Kath and the rest of the service team for all the work they've put into this. It's an extraordinary amount of work in addition to normal duties, so very, very grateful to them for that. Plus, of course, then Bennett, Conrad and other members of the Transformation Programme Office and our Awareness and Engagement team, because obviously there's a huge amount of organising around the consultation. So just I'm very grateful to everyone for that, as well as then, as Phil's mentioned, the support provides through this again. And of course, all the members of the public who have supported the events. We've had some good engagement and we've had good responses through the questionnaire, so that's been very helpful to us. So just as a way of introducing the item, as we've said before in previous consultations, this isn't a voting process. What we're looking to do is seek people's views and help us with our decision-making process and benefit from the public's wisdom on that, their experiences of our services, and help us really understand what matters most to individuals, which is an important part of the decision-making process. So I will ask Marcus and Nick shortly just take us through the options, but just as a very quick recap, the service changes that led us to this point. There was originally a 24-hour inpatient unit in Windrush Hospital. That changed back in 2014 following a period of consultation, and a 12-hour PACU was established 7 days a week. There was a further change then in 2016, which was a temporary reduction in the operating hours. And then, as you can see, as we hit the COVID challenges in 2020, there was closure of that unit temporarily, and that has continued since that point as we've responded to other pressures in addition to COVID. So it's very much been a key concern for us as to how we address what have been a series of temporary changes brought about, as you can see from the slide, predominantly, at least in the initial stages, with workforce challenges, and I'm sure touch on that shortly, but also then obviously the pressures that we've had to respond to in terms of the pandemic and RSV. So, without delaying this any further, hopefully that's a helpful introduction. I'll hand over to Marcus, who can take us through the options that we developed. Thank you, Marcus.
Thank you very much. So my name is Marcus Andrews. I'm a consultant paediatrician. I was interviewed for the post I took up here in January 2015, in 2014, and little did I know that I would be involved in this situation now. And well, challenge it has been, this is true. I'm the clinical lead for paediatrics, and my title says the clinical lead for the consultation, which sounds very grand. So as you can see, hopefully you can see from the distance the 3 options there, and as has been stated already, these options were agreed upon after a very comprehensive process of listening to the stakeholders, and particularly their desires for what could be provided in the Withybush site for children, and lots of reflection and discussion with clinicians and managers. So 2 working groups were set up, which included paediatricians, managers, nurses, parents, and representation from primary care and from the ambulance service. So we met very regularly to discuss and explore the desirable options for the service that could be delivered. The different options were then presented and appraised by a wider audience before finally these 3 options were decided upon. So the strong desire is to enhance the current services provided in light of the needs of the childhood population and their parents and carers and families. So of course there is not the option to return to the model from 2014. All these 3 options are recognised that primary care and the public really wish to maintain a good contact and access to paediatric secondary care on an urgent basis. And this is currently provided by a rapid access clinic in the Withybush Hospital site. And the desire is to develop this and maintain this further. This means that a child will be seen by a consultant paediatrician within 72 hours of referral. So with option 1, it's really the most similar to the current model, and focuses really on developing the outpatient services, and we could discuss that in more detail in due course. Option 2 returns a more limited PACU service. This is what has been desired, but of course this may limit the outpatient development. And then option 3 is to return the PACU with some additional services, such as support for radiology and some other elements of day care. So I now pass over to Nick to explain further how these options were scored and ultimately agreed upon.
Thanks, Marcus. And morning, everybody. I'm Nick. I'm the Service Delivery Manager for Paediatrics and Neonates for Hywel. Big piece of work, but I think you'll hear from us that we're really keen that we get this developed to bring some stability to the service provision. And part of that is making sure that children can access care as close to home as possible in a safer way as possible. At the moment, really major access for just about everything that isn't routine is through Glangwili, and there is quite a lot of disruption in that process. So we need to be cognizant of some of the risks that we've seen in the previous iterations of the model, which are drawn out in the papers, and we've tried to bear that in mind as development of these options being put forward. The 3 options were subject to an option appraisal process, and that was conducted by 25 stakeholders, including parents and guardians of children, but twice were participating with us from the Community Health Council at that time, and we had members of staff from the paediatric team, doctors, nurses, and administration staff were participating in the evaluation. Everybody that took part could score each individual criteria with a maximum of 10 points. So 1 point was least satisfactory, 10 points fully meets the criteria identified, and you can see the criteria and the assessment of that on the screen. Just a couple of highlights, I think, to point out. So you'll note that option 1 overall has the highest score. It does, though, contain the lowest score for accessibility and the impact on people. And that's because in all of these models, the emergency pathways will be retained at Glangwili. So if you need admission at the point of contact, you go to Glangwili, that's going to stay. And that's because we've made that system safer and more sustainable. And we've got a full consultant rota for the first time in quite a long time, which means that we provide more care for children within the health board than perhaps we'd seen previously. And the direct consequence of that, we transfer less children out on critical care pathways than we had seen in previous years. Options 2 and 3 have very similar total scores, but you'll note in that the workforce viability and the safe inter-hospital transport receive lowest scores in the sections. The important things to pull out that our workforce challenges have been recognised and risk assessed as part of this process, and options 2 and 3 deliver more if we need more staff to deliver the service, and that could produce additional complications, and making sure that system is open and stays open. We need to be cognizant of those challenges as these decisions and deliberations proceed. The inter-hospital transfer risk relates to the difficulty in moving a child that may become critically ill, particularly with an airway compromise. We're very restricted in how we can do that. The dedicated transfer service is based in Bristol. So you're talking a 2-hour window for them to respond if they're available at the time that call comes in. Our dedicated ambulance vehicle, indeed our emergency medical rehab services, and even general WAS DMS crews have difficulty in moving children with compromised airways. So we're really restricted and reliant on that crew from Bristol in the most severe. And actually, where there's even potential to deteriorate, it's a difficult conversation, and to have that cooperation from our medical colleagues across anaesthetics, paediatrics, A&E is something we need to talk about and include in our consideration. So I think that's all I need to say on this slide at the moment, but I think you'll see robust analysis to make sure that these options are deliverable and at what stage that risk will be brought in. So I'm going to hand over to Kester, and I have it now for Laura to give the feedback from the independent.
Lovely, thank you, Nick. I'm Kester Holmes. I head up the consultation team at Opinion Research, and my colleague Ang Harrod, who's a senior lead at the company. So I shall share the slides. There we go. Hopefully that is coming through. There we go. So our company runs consultation and engagement across the UK for the NHS and other public sectors. We were invited to help analyse and report the findings from your consultation that ran over the summer, the paediatrics consultation. It was a comprehensive effort engaging a number of people, as the next slide will show, and a considerably long report has been put together by my colleagues. This presentation really is the headlines for that. So I urge you to read the full report for the full detail. So, the programme was comprehensive and conscientious, as I say. The questionnaire, which was available online and on paper, and in English and in Welsh, it received 342 responses. There was considerable staff engagement via a number of events and meetings which ORS attended and took notes at and ran some depth interviews on. We convened focus groups with members of the public and service users in each of the 3 counties. My colleague Harrod ran some of them. Stakeholder meetings were offered, some of the key stakeholders and gained considerable attendance. There were numerous public drop-in events and further kind of discussions in community groups where we gathered notes and analysed and reported all of those in our full report, along with feedback coming through email and social media comment. In terms of the questionnaire response, hopefully you can see that map shows that there was reach and response from across the whole Hywel Dda area, but by far and away the largest response was from people living in Pembrokeshire closer to Withybush Hospital, which is to be expected as the proposals primarily affect those people. This chart just briefly shows in red the overall Hywel Dda population and how it splits across the counties, and then the questionnaire response in blue, showing 85% of respondents were from Pembrokeshire. But when you look at the population in purple, whose nearest hospital is Withybush, that very much more reflects that the consultation response matched the population that the proposals affect. So in terms of the views that were gained on the options, these 3 charts in green show the proportions thinking each of those options was good. In red, those thinking it was poor, and in kind of yellowy beige, the proportion thinking it was neither good nor poor. I think it's fair to say that the views around option 1 and option 2 were probably divided. On option 1, slightly more people suggesting it was poor rather than good. On option 2, slightly more suggesting it was good rather than poor. But noting on both of those options, if you include the proportion that thinks they were kind of neither good nor poor, along with those who say it was good, then there is an absolute majority for both of those options in terms of support. However, it was option 3 that gained the greatest levels of support, with more, just about 2/3 saying they were good and a further 17% kind of on the fence. So option 3 was definitely favoured in terms of the statistics there. In terms of the child-friendly questionnaire that was carried out, It received a relatively low level of response, so I think around about just over 20 respondents. Results or views on the three options were slightly more favourable compared to the adult version, with more than half suggesting option 1 was good, 2/3 suggesting option 2 was good, and by far and away the majority, 90%, suggesting option 3 was a good option. So those are the kind of statistics from the questionnaire. I'll hand over to Angharad to talk through some of the more interesting detail that was gleaned from respondents, both to the questionnaire and all of the other activities.
Thanks, Hester. So if we look at option 1 to start, which brings, some expanded outpatient services to Bush Hospital, and things that people liked or were positive about. So the main thing really was that people felt that there would be more care closer to home for Pembrokeshire residents, and this is the kind of cheapest and least complex of the three options, therefore deemed to be the quickest to implement. And it was also seen as the least confusing model for service users. So because there's no part-time PACU at Withybush under this option, it was felt that people would have a better idea as to where they would need to go for what and when. People were positive about the fact that there'd be more outpatient provision on the rapid access clinics. There was a lot of positivity around these two. Also deemed the easiest to staff with no PACU in place. And really that it kind of enhances the current situation, which is seen to be working very well, and was introduced to mitigate the challenges that led to the temporary service changes. So the kind of overall feeling was that this is better than what was in place now. It's fair to say people perhaps weren't going overboard in their praise for this option, but they recognise that it offers more than the current situation. Some things that the sort of main criticisms or the negatives around option 1 is that there isn't the return of a PACU to Withybush, and that people feel that more services are needed at Withybush generally, including radiology and dressing change, for example. There's limited support in Pembrokeshire under this option for children and young people with long-term and or complex medical needs. And there were concerns around the ability to staff an expanded outpatient service given the health board's recruitment and retention challenges within paediatrics. So moving on to option 2, with the pattern returning to Withybush on a Monday to Friday basis, people were positive about the return of PACU in Pembrokeshire, feeling that it provided reassurance, peace of mind for families there, and it provided better and more timely access to paediatric care and advice for Pembrokeshire residents. Of course, less travel time for Pembrokeshire children and young people and their families, bringing those services closer to home, and in theory then would take some pressure off Glangwili and local GPs who were said to be taking on a number of consultations with children and young people, particularly out of hours. I'm going to go on straight away to talk about some of the positive responses to option 3, because some of the negative views on options 2 and 3 are largely the same, so I'll cover those off at the same time. So this option 3, of course, many of the similar aspects as option 2, with some non-emergency treatments as an addition. Again, people felt that this would see the return of more services to Withybush, including daycare, radiology, and dressing change, which was really positive. The next 3 points kind of echo what was said for option 2, positive about the return of PACU, for better and more timely access to paediatric care and advice, and less travel time for children and young people and their families, and services close to home in Pembrokeshire. People were positive about the provision of staff training and upskilling under this option, which was felt to potentially be a way to improve retention and could negate the need for paediatric input in some cases, streamlining processes and reducing waiting times as a result. The plans under this option to improve or bring a dedicated waiting area for children and young people at Glangwili was seen as a real positive. It's frequently said across all consultation strands that the A&E environment at Glangwili is inappropriate for children and young people, so any improvements to this was really welcomed. Again, feeling that this option would take some pressure off Glangwili, and it's fair to say for some people this was the sort of least worst option. These people perhaps didn't especially like any of them, but this was considered the best out of the three. In terms of concerns then around options 2 and 3, there was still a feeling among a lot of people that there was still insufficient services at Withybush. There were concerns around the limited PACO hours, particularly lack of evening and weekend cover, and also the fact that there might be more limited and outpatient rapid access clinics because of the introduction of PACO. And as mentioned under option 1, these were considered positive additions, so the prospect of having less of them was then seen as a negative. There was some potential confusion or concerns that there'd be confusion around having a different model of service during the daytime compared to the night, and staff in particular raised potential sustainability issues around these two models, so particularly concerns around staffing and sustainability of the PACO at Withybush, and a feeling that specialist treatment and doctor cover may be fragile if it was split between Glangwili and Withybush. And therefore there would need to be significant recruitment to avoid destabilising the service was the concern on this. It's certainly fair to say there was some confusion among respondents that completed the questionnaire about why options 2 and 3 would be less outpatient or rapid access clinic activity. Some felt that there was plenty of space at Withybush previously, so questioned why then there was not enough room to then fit everything in. So that's an issue that will need more explanation, I think, if either of these two options are taken forward. And then views that related to all three options, really, it certainly felt positive that it'd be better to have some services back at Withybush than none at all, and all three options, of course, offer this. The rapid access clinics were welcomed, but lots of people questioned how exactly they would work in practice, so there would need to be some clarification around this. In terms then of some concerns around all three options, for many, none of the three options were acceptable, because there would still be a need for difficult or lengthy journeys from Pembrokeshire, especially the further west people are to Glangwili, which of course is especially difficult with a sick child. There may be staffing issues, particularly under options 2 and 3, and given current recruitment and retention challenges within paediatric services, that was a real concern for people, and difficulties around accessing GP appointments. So that this could mean that families would just still go straight to A&E rather than seeking a GP referral to a Withybush PACO or a rapid access clinic. I think the consultation certainly identified the importance of signposting. So one of the key issues to come out of the consultation was the potential for confusion from having part-time PACO services at Withybush. And this was enough of a reason for some people to prefer option 1 because they felt it provided clarity for families on where to take their children in urgent or emergency situations. So if option 2 or 3 were taken forward, there would need to be clear pathways and proper signposting to ensure residents and healthcare providers know what can and should be accessed where and when. So thinking about the DAV, the Dedicated Access Ambulance Vehicle, it was seen as an important and positive resource, but there were lots of questions around its availability, whether one is enough, whether it's a ring-fenced resource and how that works, and whether the paediatric expertise of the paramedics operating it is there. So there's a feeling that members of the public don't perhaps know that the DAV is available as a resource, so informing them about it would be important in offering reassurance, really. And there was also a wide-ranging view, really, that whichever option was chosen, that should include improvements to the Glangwili Emergency Department, for example, a separate waiting area, additional training for wider staff, and the PACO at Glangwili, where the staff were consistently praised, but the physical environment was thought to be in need of improvement. And again, staff training at both sites was something that people were really in favour of. So some alternative suggestions were provided. By far the most common was to restore full paediatric services to Withybush, although there was also recognition that this, wouldn't really be possible. Some other comments and suggestions were to amend proposed hours for services at Withybush to include evenings and weekends. So something like 9 a.m. to 10 p.m. and or Wednesday to Sunday rather than Monday to Friday, and to make more use of telemedicine and digital options, for example, video triage between Drangwynio and Withybush. And there's a number of other suggestions there, but I'm not going to go through those in detail because I know we're short on time, and I know you've been able to see them and consider them already. So just to finish, some points on equalities and health inequalities rising from the consultation. So there were concerns about the ongoing impact on children and young people in Pembrokeshire and some parts of Ceredigion, mainly in relation to a lack of emergency and inpatient care at Withybush, especially those requiring inpatient admission, those with complex needs requiring ongoing care. And there were a lot of comments about the impact on the ability of family members and others to visit children and young people in hospitals that are some distance away, and the lasting impact this can have on them. Specific concerns then for families with disabled, neurodivergent children, disabled parents, parents with other children or caring responsibilities, and single parent families. And there's certainly potential for disproportionate impact on low-income families, mainly due to increased travel costs and sometimes accommodation. And this was extended to concerns for families without access to private transport. But there were some positive impacts identified for Pembrokeshire residents, particularly if there was a return of a PACU model to Withybush. So children and young people and their parents, etc., would be positive for them in terms of having their care closer to home. Also some positives for premature babies and their families, and being able to get that follow-up care closer to home. For low-income families, there would be lower transport and accommodation costs. And again, families without private transport, it would be easier for them to get to Withybush. And then also for children and young people with additional or complex needs and their families. And then to finish, also some positive impact on other services potentially under some of these options. So the ambulance service, A&E and GPs, and also traffic congestion potentially would be reduced. Of course, helping the health board to its net zero commitments. Thank you. Yeah.
Thank you, Howard. Thank you, Kester. So I will just conclude and sum up now before we go into discussion. So following the consultation feedback report from ORS, we've had the opportunity to take it into a number of groups for the conscientious consideration process that we've described in the paperwork and has been mentioned already. Some of the key themes identified through that are listed on the slide there and within the pack. We have also given consideration to the alternative suggestions that came through that process, and there's a paper in Appendix 4 that summarises that. And then the final point is that we have again received a best practice award for quality assurance in relation to the consultation, so just provide some assurance for the board on that. The EQIAs have been mentioned a few times, so we've updated those to reflect the feedback, and as I mentioned already, they will be a dynamic document that will help us with whichever option we choose, and further work will be done on those when we've decided on an option. But some of the key themes through that process are listed there, and I think they very much mirror the comments we've had through the consultation report itself. So just as a way of summary then, just to help the board now as we move into discussion and consideration of the report, this is just a quick summary slide of the feedback from the consultation process. As you can see, the scoring of the options at the top from the stakeholders that developed the options initially, the feedback then in the charts below from the consultation. Some of the key themes that we've identified through conscientious consideration and consideration of the alternative suggestions and then the EQIAs. And with that, I will conclude, Chair, and move to some discussion.
Right, thank you. Phil, nothing more you want to add at this stage?
No, I think
Right,
we need to get into.
Okay, fine. So, okay, keep your hands up so I can catch everybody. Helen, let's start with you.
We're grateful to the Health Board and colleagues in the transformation and in paediatrics for a inclusive process to the engagement from the very beginning and involving carers, families from the very beginning of this process. With that said, whichever option the board decide to do, clear communication on how to access services from clinicians in the primary care, because as we know in GP practices, some GP practices rely on locum, and locums will need to know how to refer children, and clear access for the parents and children how to, and continuous communication with those people who use the service. That's all I've got to say.
That's great, thank you. And Helen, thank you for your input to this process. Right, other questions, Dan?
Yes, I have a question about rurality and transport, and it is within the papers in regards accessibility. My concern is that we, in the Pembrokeshire area, we have significant numbers of lower income families which would be impacted by whatever decision we make. So how are we engaging with our population to really look at how we can help that cohort of families and make it easier for people to access?
Right. So we've looked at activity across the 3 counties as part of this conversation, and there's only one number that is really important. 80% of acute admissions that are coming to Glangwili are not admitted. So the vast majority of our acute admissions are returned home same day. The vast majority of our overall contacts are planned to our outpatient, our rapid access facilities. So the vast majority of people that need to access services can do so in a planned way. We're looking to interfere, if you like, with the 80% of children that come to Glangwili, so that would incorporate people from Pembrokeshire by making sure we can provide a service through rapid access, because those children perhaps do not need to see a paediatrician that day, but they could be seen within 3 days. And so the idea would be that if they did see the local GP and the GP just felt they wanted a paediatric opinion and it was a Friday, they could be booked in potentially seen on a Monday, the day of the transfer. For the ones that fall into the urgent emergency pathway, by definition, they're unwell. They will more than likely need ambulance conveyance, particularly if they're local, if they're seen locally. And we do have our dedicated ambulance vehicle, which is ring fenced for women and children's responses. It's a 999 resource like any other ambulance, but it's over and above the Pembrokeshire establishment of emergency response vehicles. And those crews will convey children. They do it from a 999 call, they do it from planned calls, they do it from GP calls, and they take them to Glangwili because the likelihood is those children will need same day assessment, same day admission, and likely overnight stays. And we've not seen any negative feedback from that. So really, as part of this whole process, and to make sure the interim models are safe, children are trying to be kept as local as possible, and that 80% that are coming to Glangwili, because the interim change at the moment, we're looking to return as many of those as possible, depending on the option that's chosen today, to mitigate the need.
Can I just follow up on that a little bit before I bring in answer the questions? So that's because under option 1, there's going to be the rapid access, proposed as a rapid access clinic, which is not there now. So that's why there could be more children who don't have to make, or families that don't have to make that trip to Glangwili. Is that, am I understanding what you're saying correctly?
Yeah, that's right. So we do have a rapid access clinic at the moment. We're looking to build on that, enhance it. It's almost, it has the potential to schedule unscheduled care. So to book in locally. So that could be an A&E clinician that will book into that clinic the next day. And Kath might have some additional comments.
Yeah, so as I was saying, Cathy is consultant paediatrician based in Withybush for the majority of my work. Expanding on the options and elaborating on what Nick said is that at present we do run a rapid access clinic in Withybush, and this has been established for a long period of time, and is running very effectively. So we pick up as well as urgent outpatient referrals that need to be seen within, taking it possibly a bit longer, a week, for example, but also GP, midwifery and health visitor referrals that can get seen within the 72-hour period. So that is working effectively. However, our issues with delivery consistently of it at the minute relates to staffing. So even on an option 1, where we are guaranteeing that option Monday to Friday, it will be an expansion of current services. The 3 paediatricians that deliver it at present are either part-time or have a split job planned week between Withybush and Glangwili. So we're not there consistently through the week. So at the moment, we have at least 1 day per week where a rapid access provision is not provided in Withybush, which we can't cover. And added difficulties come in at the moment from annual leave, study leave, or clinical commitments, because 2 of us who are working this rota have clinical commitments in Glangwili and support that rota as well, which we can't come off because that will destabilise Glangwili's rota. So an option 1 would be an enhancement of what we've got running currently, which is as effective as it can be in the current situation.
Very much clarification, thank you. I've got Michael.
Yes, thank you, Chair. Apologies for being late, and I had flagged that in advance. I was just on the transport issue again, which Dareth rose, because clearly that's a major concern of a lot of our people. So let's talk about things being discussed in the implementation process. So how much will issues like that be able to be discussed further and bottomed out, and how much of that is still open for refinement and development in that respect? Because I think that's an area which maybe could do with further development and further input. So how much of that is available for that in the implementation process and the implementation kind of working groups or committee or whatever it is, that the mechanics of that.
Like to take that.
Yeah. So absolutely right. So transport will be a major part of our implementation strategy. We've got existing facilities to transport children home, particularly out of hours, with our hospital negotiated contract taxi services. I've mentioned this before. We hear transport and we know the concern about transport all the time, but the reality of how often it's asked for is limited. We've got some work to do, acknowledging the opportunities that we have with the dedicated ambulance vehicle, and certainly Welsh Ambulance and Health Board are looking to do some communications around that. We're actually, with the Director of Operations, looking to review the DAVs. It's due for its commissioning review anyway, and as part of that, we'll be making sure that we can enhance its knowledge in the community. But it's also important to note that the general public cannot access it. It has to be through the 909 streaming system for the most appropriate use. Taxis are probably the most cost-effective way of repatriating children that come on the emergency pathway. Those are already in place. We've confirmed actually with the transport team that those taxis are disabled access to. And so if children do come with wheelchairs, as an example, or some complex care packages, we would have a facility to repatriate them. We shouldn't be discharging overnight. We know that anyway, but if it was appropriate or the family wanted it, we could accommodate that. And then we've got our non-emergency patient transport system with the Welsh Ambulance in the daytime that can be looked at. So getting people back is something that we can cater for and make sure we publicise that and perhaps put some more pathways in place to understand its availability.
Michael, did you want to
come
in on this? But,
okay, just one more. Yeah, thank you, Chair. Just let's talk in the quality impact assessment and mitigation of the policy, particularly policy in respect of those people who might have difficulty affording or accessing transport, those kind of families. So my ignorance maybe, but I'm not particularly aware of that policy. I wonder if that policy, if this goes ahead, in the light of what we're talking about, would that be potentially further refined and developed and maybe given more publicity? Because I think if we have a policy, it must be a policy which is a living, breathing, up-to-date and relevant policy. And I think and meeting the new challenges which new strategic decisions come with. So is that policy something which would be looked at, worked upon, taken feedback about and developed, or is it set in stone?
So the policy referred to as the hospital travel cost scheme procedure, and that's how people on benefits in particular are reimbursed for their travel, and that's the same for every NHS access across the entirety of the system. Yes, it can be built on and looked at, and I think that the conversation, so paediatrics is different in the risk, how we move those children, and the complexity of the moves that require the children does need some additional thought. We've got that, I think, with the disabled access. It's just a conversation as part of our implementation with our clinical colleagues. Are there any additional considerations we need to make? Is there anything else we need to commission? Just noting that whatever happens on transport, it becomes quite a significant expense because of the nature of what we need to provide consistently, but the number of access is likely to be low.
Okay, thank you.
I'm going to bring Phil in on this, and I know what's going on, but Phil, do you want to come in on this item?
Yes. Clearly, there's a lot of feedback about transport from the public, from a lot of different angles. And whilst we have done a lot of work, we do have policy, and there's been a lot of thinking done about transport over the years for this service. However, given the large amount of feedback that we've had from on consultation, and I think given the gap between the concerns that we see in the consultation and those members of the public picking up the transport offer that you're talking about, Nick, I do think it's going to need further exploration. I do think as we go through that implementation process, we're going to need to engage with service users as to why that might not be picked up. So I think through that implementation process, I think that's going to be really key. Whatever decision we make, because I think the concerns will be there, whatever decision we make.
Lee, do you want to answer this? Or is that okay? Steve, do you want to come in there?
Yeah, well, most of the points have been made. Of course, there are a couple of things in this, and we know that transport and access is a much wider issue than it just pertains to paediatrics. Of course, the desire within the Healthy Middle West strategy is that we move services further west into a new hospital, and the use of Down Blue for that was dismissed actually quite an early stage of that process in 2007, 2008. So there's an acknowledgement it is already too far. As Nick said, there are a whole range of things currently in place. I think for the board, in considering this option, that idea of a formalised work stream about what more we can do, I think is really important whilst we have these policies. I guess the bit that concerns me the most is not those people who turn up and in some way we don't implement the policy in the way that we really want. It's those who choose not to, who we don't even know about, who are probably at the greatest risk. So there's just something in the work stream about how I think it's still said we work with those families to both see whether the policy is known about it, but whether it also should be extended in other ways for this particular group. So I think whatever we recommend going forward, having that formal work stream, having that reporting back through the relevant committee, I think is going to be really important to make sure we do that, acknowledging that Vanguard is in the right place for a lot of our population and that place.
Right, so I'm looking down my list. Maynard.
Yeah, thanks, Chair. In the consultation, it was mentioned that use of telemedicine and digital support services, but I can't see much in the actual documentation that we've actually looked at that in great detail. I may have missed it. There was a lot of information in there. I was just wondering if you could tell me a bit about whether you considered any digital support for county services such as GP consultation in real time, and things like that.
Thank you. Who would like to say that?
I think it would be me. So we agree that yes, we should be enhancing the technology. We are behind the times with our current setup. I agree. We do want to move forward this, but we haven't yet. We have discussed models of communication with primary care. I've discussed with individual GPs. They've actually said a telephone call at a certain time may be the best way. Obviously, a 24/7 digital communication has been postulated some years ago. For instance, with the A&E in Withybush, obviously A&E in Withybush, where children may appear out of hours, they are supported by the team in Glenwilly 24/7. There was some discussion about the use of telemedicine there, but there are concerns about the clinical assessment via an iPad and seeing something is not the same as being in the room. And I believe at the time that there was a bit of a clinical risk for those who would be giving the advice. It's not quite, you have to, the decisions about transferring a sick child have to be made by those who have the child in front of them. So I do believe that some concerns were identified with the use of some forms of digital communication. I think we've got to get the right type of digital communication. I think we need to explore what is done in other places. And I confess that has not happened yet.
It's a comment on
Sorry, I'd like to also add, I think when you're exploring virtual consultations, virtual opinions, I think I have to sort of be frank with how Withybush is staffed, and even with any option likely to be staffed, it's not going to be by many. It may even be a single consultant on the floor on the Monday to Fridays. And I think we have to be honest and open and ask what you really want that consultant to be doing. Do you want them to be doing 2 hours of telephone or telemedicine consultation supporting GPs, which may or may not be used, because you don't necessarily have 8 GPs lined up waiting to talk to you? Or do you want me seeing a PACU admission, an outpatient clinic, or a rapid access? And I think stemming from the options and the work that is going to be both challenging and exciting for those of us that are on the floor as our managerial teams, is I think we have to be really asking, what do you want our clinicians, or for example, nurse practitioners, to be delivering? Because you may be taking to develop services, taking from one pot to provide another. And I think that needs to be recognised in consideration.
I would agree with that comment entirely, because I've seen too many situations where you've got Peter to pay for, and that is something we do need to do aware of. But the follow-up was more of a comment as well, in terms of whether things like the ORCA range of apps that the health service procures, whether those can assist in prevention of and supporting parents in looking at things to know whether they need to consult a clinician further, or whether it's just part of a routine virus infection. But that's more of a comment than a question.
You was on my list, so when you come in, can you talk about that as well, please, the digital side? Roger.
Yeah, thank you. Just one, if we look at the SPA, if we look at the recommendations, it's just for clarity really. Obviously there's been agreement on the preferred option. If we look at the bottom and note the requirement for the services development implementation plan, setting out how the preferred option will be operationalised. And that will be presented back in board in January 24. From my understanding, I'm just wondering kind of where is the scrutiny in that? Is that timeline a bit tight in what you're asking, or what? I'm just thinking we need to have some kind of scrutiny on that implementation plan before it comes back to board. And I just want your views on how that is implemented and comes back and everything. All the scrutiny has been done before the board in January. We haven't got much time. Christmas as well.
I'm happy to take that, and I just may want to add comments. I think this reflects, I suppose, the desire we have to try to move at the quickest possible pace we can, because we've recognised there's been a long period of time where there's been uncertainty for the public, so we're trying to not delay and to come to conclusions as quickly as possible. So that's why we're pushing the pace. That's what we're trying to come to bring a plan back to forward in January. Just for clarity, that will be the project plan, if you like, that will set out the key things that we need to address over a period of time in order to operationalise the model, and that will give us an indication of what we're going to need to do, but also the likely time scale associated with that. So we think from a development of that plan point of view, that can be achieved by January, but I guess there is a valid question, I suppose, about that point of committee scrutiny, and if you wanted ESTOD, probably the relevant committee, if you wanted them to scrutinise that before it came to board, then obviously you have to factor that into the timelines. But we were aiming to just bring it back at the earliest opportunity for board consideration, and that is what we've done with the land consultation and other things previously. So it's not out of the ordinary, but if people want to scrutinise that, we'd be happy to do that.
Okay, perhaps take that outside, because what you've just explained is, I think, less than probably you thinking you're going to bring a full-blown plan, whereas it's actually this is how we're going to develop. I'm just looking at Yvonne, you probably believe that.
Thanks.
Okay, thank you. Ardiana.
Excuse me. Thanks, Chair. The core of the access and equality impact assessment is really around the duty of quality, that is the equity. So I wanted to just a little bit pick on that, because equity as a legal core of the quality takes account of the need, direct account of the need, which by implication has then the quality and the benefit. And if we're looking at just the access, we have to look at the service that is sustainable and resilient, and that it has all the 6 domains of the quality. And that's where the options that we might want to choose will have to build in all these continuous impact assessments and continuous provisions for whether it is policy, whether in the service development and implementation, but not to lose sight that actually we don't want an inferior service just because of the access. And that's why the equity, I think it's key, rather than just equal a service for everyone.
That's really helpful, Ardiana, thank you. Okay, do we want to come back on that, or no? I think it's a very helpful statement, thank you, Ardiana. You do sometimes get those things sort of confused, I certainly do, but thank you for that. Hugh.
Yeah, diolch Cadeirydd. Just reference the digital conversation, and I think a very fair question, Maynard, and one that we need to think about more broadly. I think there's a broader piece of work around how we connect each of our sites up, especially in kind of on-call arrangements and out-of-hour arrangements. But and there's all sorts of exciting technology we could be talking about. So, I don't want to limit our thinking in that respect. But we need to make sure that it kind of treads lightly and that it supports change and not drives change in itself. And I think the points that you both raised actually are very pertinent, in that what I'm conscious of is I want this to support clinical decision making, support the challenges that you're facing, and not inadvertently introduce other and potentially greater risks. So we need to make sure it's part of a mitigation of risk and not enhance risk. So we will take that away and think about that as part of our broader digital response in due course. Coming back to the paper today, I just wanted to reference the financial implications quite naturally. All of the options that we're talking about do represent a net investment, and there will be for us going into next year's planning cycle a consequential trade-off, because the investment that we make today will represent then a greater challenge for either other services within the directorate or other services more broadly, as we are in a resource constrained environment. There is no indication of further funding, significant funding coming in the next few years. So we do need to be mindful that there will be trade-offs for other services as part of that. Clearly, that becomes a bigger impact for us as we look at options 2 and 3 than option 1.
Okay, thank you. That's important, because to sort of town-wide as a board and the position we're in, as you say, there's trade-offs, there's also benefits, realisation of things like that, as well as policy. Thank you. Ewan.
Thanks, Chair. I'm going on for a slightly different angle in terms of, with regard to the consultation, it's good to see a kind of, substantial response, as kind of Phil noted. But I think what I would be interested to perhaps tease out in terms of giving us as a board context and perhaps framing that feedback is, whilst we can see we've had 342 questionnaires returned, we've also had 780 attendees, which we've utilised through going to existing community groups and settings. But as this is a service which is looking at children and young people and vulnerable families, is there any data in terms of how many actual respondents and people who engaged were parents of young people and families, particularly? Because whilst within the data, 28 participants came to focus groups, without something too detrimental, those are often secondary perceptions from well-meaning individuals within our communities who have an opinion on the general health service within our region. What I would be more interested is to find out is, have we actually had those primary perceptions captured from those individuals who will utilise those services, rather than people who just have an opinion on it? I don't want to kind of disregard, because everyone's opinion is valid, but I think when we're looking at such a sensitive area in terms of delivery, I would be keen to find out below the consultation data that we've had, how much of a percentage is actually coming from parents of young people who may currently or may in the future be utilising this service.
Shall I take that? I mean, it's a very good question. I'll let Angharad come in as well in a second. I mean, there will certainly be some respondents to the questionnaire who are not parents, but I think there is also data in the full report showing how many are. And I'll try and get it open and give you a figure in a minute, but it is a reasonable proportion of people that were parents. So I think that's reassuring. In terms of some of the activities, in particular focus groups.
Yeah, so all the in-depth engagement, particularly the focus groups, we screened, and all of those participants were parents with children under the age of 18 or were grandparents who cared for children on a regular basis.
Okay, I mean, that's great to hear. I was just, personally, I think I was slightly disappointed in terms of the volume of numbers, and that's no kind of, detriment to the work which has been done, which I think is fantastic. When you look at the potential opportunities to get that robust kind of data and intelligence to inform what, as I mentioned, is a sensitive service. Just in Pembrokeshire alone, there are 52, 53 primary schools, and you're thinking, well, the average kind of school roll within Pembrokeshire is around 160. And if you multiply that by the number of parents, you're thinking there is a cohort there which is really applicable to this consultation of about 6,000 to 8,000 people, depending on single parent households or two parents, whatever it might be. And I just wanted to make sure that we as a board have got that assurance that we've got the right cohort in terms of that engagement. And as you say, parents have been involved, which is, assuring. But I think, perhaps it's just making sure that we don't always listen to the loudest voice within our communities who are well-meaning, but I think we have to be very specific on the audience to support our staff to make sure that what is coming through for them is relevant, realistic and applicable, so they can work then collectively to make sure that we are going for the right option.
Nick, do you want to just...
If I can just add something more. So I attended nearly all of the engagement sessions, all 50 odd, I think, in total. And prior to the start of the consultation, we were out meeting with children who access or may want to access, and if they don't access and they're healthy, lucky, what do they want to see in a service? And a lot of the themes have been built in from children's responses directly. I will add the general feeling from a lot of the people that we engage with, we're going out for the first time communicate that we want as a health board to put something back into Withybush. And if you look at the context of how Withybush is perceived by the public at the moment, it was refreshing to them that this is not taking away, this is coming back in their perception. And we feel that actually that's probably impacted on how people have responded, because this is good, this is something coming back. And that certainly came through as a theme when we were speaking to people at every single event without fail. Nearly all the people in the public events were families. There were a few local groups that were obviously out to have an interest for other reasons. Again, they were quite supportive of the fact that overall this is about improving investment in the locality. So the reach has been huge, or at least the attempted reach has been huge. But I think there are other reasons at play as to why perhaps we haven't had the biggest feedback we thought, but we don't think it's disproportionate.
No, that's right. If I may, I mean, if we were to do a consultation affecting all residents of Howell Bar and we received a response of around 1,000 responses to the questionnaire, I think we'd be feeling that was pretty reassuring. The population here is only a third or less of the overall, and the consultation questionnaire response is about a third of 1,000. So it's not disproportionate. It's not all about the numbers, it's about the efforts to engage, and it's about the cross-section of people we have heard from. And I think everybody feels that's pretty good. So we're not too concerned, although the points you make are good.
Just to kind of add to that, we've had the Best Practice Award from the Consultation Institute, just to give you assurance in terms of the process and our endeavours to do that really good engagement with the groups targeted.
Thank you, it's really helpful conversation. Anna.
Thanks, Chair. I wonder if I could just draw out a point around the case for change, which I think in the papers before us today is framed largely in terms of operational sustainability, and I think we all understand why that is. But one of the things that we would typically consider in where we locate services and how many different doors into services we have would be, is there sufficient case volume? In other words, is there critical mass of clinical need for clinicians to maintain and enhance the skills that all of our communities would wish to be on the receiving end of? I wonder if I could just ask for some clarity on that issue. Is that an issue that is relevant in this case for change, or is there sufficient case volume within Pembrokeshire for a Pembrokeshire specific service?
Who wants to take that?
Come back in and perhaps, yeah, there is. So our current facility is used to the max. If you're looking at planned care, the vast majority of contacts is planned care. If you're looking at the ability for our clinical colleagues to keep up to date in terms of the clinical practice, that's clearly evident in routine care. But as Kath mentioned earlier, our colleagues in Withybush take part in acute rotating Glangwili, so their acute skills are maintained as well. So we've got that provision across the health board, not just focused on Withybush. We know, I think it's 4 to 6 children a day on average are coming into Glangwili from Pembrokeshire. Please don't hand me that, I'm sure that's the number. You start bringing that back in. If you're talking about a clinic, we run a clinic with 6 to 8 patients, depending on the time scale, and depends on what requirements they can need and how that follow-up will look as well. So yes, there is the critical mass to have a service in Pembrokeshire. The complexity of the PACU element, that's different because that's introducing a risk that we need to make sure that we can manage and sustainably provide without introducing risk to children attending, because there's now an additional service at Withybush. And I say that because I mentioned that pathway. RSV we've not talked about. I don't want to dwell on RSV. We've changed how we look after children with respiratory presentations through the process so far, and what we've seen as a direct result of that, people have moved as an emergency from Withybush, where they ordinarily wouldn't have been presenting in that way. They're treated immediately on attendance with different oxygen therapies as soon as they hit PACU. Whereas previously we would probably have started that therapy on the ward. So they're intervened actually sooner through these processes, which means that for the most acutely unwell, the critical mass has to be retained at Glangwili for a variety of different reasons. Whereas the more planned care, and in that we're talking about people with complex needs, long-term conditions who might be needing to see 6 or 7 different therapies, doctors, specialists in their appointment making. They are constantly on the road going to different places. We've got tertiary care consultants that provide care in the locality that could do that within this type of facility, which at the moment, for various reasons, they might have to be going to Glangwili for that element of care as well. So there's planned care, because this is urgent and emergency, the focus of this, but there are things that sit in the back of the entire paediatric stream, community paediatrics. There is a utility of the resource that is not discussed as part of this process. But focusing on the safety netting of those urgent emergency care, yes, we've got the critical mass. We've got the critical mass to maintain our skills, and we've got the right resources in place. Whether we've got enough of them as part of the workforce planning, but we've got the right skills in place to look after children.
Bill, do you want to add?
Yeah, I suppose, because I think in the question, so there's a number of angles to that I was considering. I suppose I think one concern might be by Institute of Pacu and Withybush that the numbers might mean that it disrupts the critical mass at Glangwili, and therefore suddenly we haven't got the critical mass there. I don't, given the numbers are quite small, I think that's unlikely to be an issue from my understanding. In terms of the critical mass of Pacu and Withybush, from a sort of medical professional perspective, I think as Nick alluded to, because for example, and other consultants are working across both sites, I think often you worry about risk of de-skilling. I think that's very unlikely because of it would be in the mix of all the other clinical activities they undertake, plus they would work across sites as well. So I don't think that's such an issue. I think though the thing that probably is an issue is that it is very small numbers. There are lots of activities that we need our consultant paediatricians to undertake, and other clinicians as well. And it just means like we divert into that. And I think that there's a bit of a question there because it is small numbers.
Okay. Can I just briefly come back on that, Charles? I think that's helpful to draw that out in today's discussion so that we can understand the nuance within that. But I think what I'm hearing is that actually the configuration across the different three options that we're looking at is important to maintain the quality and safety of care for children and their families across our entire footprint. And therefore, all other considerations fall in behind that. So the practical things around how do people get to it, how do we move people between sites, all of those things are practical considerations that have to be attended to. But the number one thing has to be about how we configure services across a rural population in a safe and effective and high quality way as possible. And this allows us to achieve that in a way that we could not do if we treated each county in isolation of the other. If that is a fair summary, I think that is therefore an important thing for the board to be considering today.
Catherine, do you want to go?
Yeah, thank you, Chair. I think alluding to sort of points that have been put on the table, I think as the years have evolved and the changes happened in Pembrokeshire and Withybush, going to a limited PACU, the time cutting down, and more of us being amalgamated onto the Carmarthenshire paediatric rota, I think that has enhanced those of us that do its skills, maintained it. I feel, I hope my clinical lead agrees, but I can face the challenges in an acute setting and carry it across both county borders, and maintain my skills as Marcus would in Glangwili. I think we can rest assured that our training and keeping our skills up to date is as good as Carmarthenshire as well. We certainly have to attend all the same life support skill courses. And again, I can take my skills to the special care baby unit as well. So I think our quality and safety is maintained in that way. And it's not just both with the day-to-day service provision on the ward, and we do the on-call rota as well. So I provide as much acute care as a Carmarthenshire consultant does as well. So that translates into our practice and being able to maintain a safe and good quality service in Pembrokeshire as well. And certainly that's something we could look as we bring clinical models into place. But I would have confidence that we are addressing that already.
Thank you for that.
Thank you. Fantastic report. Actually reassured to hear your comments about consulting part. What I'm concerned about is the other staffing levels.
Can you speak up?
Sorry. What I'm mostly concerned about is the other staffing levels. You're getting cross training with Carmarthen and Pembrokeshire, but do we have enough staff to open up a PACU or Withybush? I mean, in your it was a considerable concern amongst the questions and the consultee types, and you did talk about increasing allied health professionals, physician associates,
and paediatric nurse training and promote fellowships, but that's all time. So if a decision is made, can we open it? Can we start it?
So this falls into the implementation plan. I think there's two key things that will give us a timescale. Workforce plan being probably the most important. So it depends on what the option is decided today as to the extent of the staffing required. We do, since this process started, we now have a physician's associate within paediatrics. She's the only one of two in Wales. So we're making some, it's only a start, granted. We've got 4 advanced practitioners at different levels of training. One has just qualified, and we've had one that's been qualified for a amount of time, and the other 2 in the training program. So we've already started the game, but it's not like we're going to start a 4-year program of training. We've already got people within that pathway, and that provides a different workforce model opportunity than we've seen in previous iterations at Withybush. We as a team and our clinical colleagues in particular need to understand how that would impact the delivery of care locally, because at the moment we're talking essentially about a medical model with nursing support. This could be looking at having a multidisciplinary team providing that care and what that looks like. So there's more to be done in terms of that pathway work as part of the implementation. Nursing wise, we've got reasonably good recruitment, particularly through streamlining. And so if there is a gap, and when these papers produced, things have changed in the last 18 months, 2 years in terms of staffing profiles. So the workforce plan would help us identify what recruitment is needed and how quickly we can get that system into place. So it's noted, and you note that as the options build, the risks around workforce get higher. We mentioned that earlier, recognising that disruption is potentially there.
Thank you.
Right, I've got Chantal and Andrew, then Helen, and Catherine. Catherine, was it on this point?
Yes, it was. Yeah.
Do you want to put it
I'd like to offer a professional opinion to answer that question. And by professional opinion is no, we don't have the staffing at this moment in time to provide any of the options and any of the models in Withybush, either it be medical or nursing teams. In my opinion, this is one of the areas that needs a lot of work on with the implementation model, and recruitment, as it's in the other options, as we've worked through the years and times have been cut down in Withybush. It was noted and it was bold on the slides that it was due to recruitment issues. Okay. This has to be looked at and considered, because this could hold back plans. We don't have the staff at the moment to implement any of the options from Monday to Friday, as I alluded to a little earlier. And I think this is one of the main things, is that even though we're working through these models, the Pembrokeshire feeling, and they have lost services over the years. We saw that in our first slide. And what children and young people need, and their parents and their guardians need, and the staff that are providing this service need, is the robustness of the model going forward, that we can deliver the option, and it's going to be delivered. And that will iron out so many problems. It'll iron out where parents know where to go, what times they know they can go there, where GPs can access. And it'll iron out a lot of problems, because it's got to be delivered consistently, and that values and respects our families and our children and young people then. So it's not, oh gosh, we haven't got some staff today, we'll have to close Withybush because everyone's got to go up to Glangwili. We can't be doing that as we evolve these models. So at the moment, no, we don't have the staff. Thank you.
I think when you say the certainty about what we're working towards is going to help. We're not going to magic up people, but it will at least help that you know which direction we're going. Okay. Phil, you want to come in on just this?
Yeah, if
point?
possible. I mean, I think Kath's articulated that really clearly for us. And the whole review of this was about improving patient safety, and to do that, of course, we looked at what sort of staffing we would need to improve patient safety. There's clearly a difference between the options, and when you look on page 7 of the SBAR, in the estimated ongoing revenue increase above budget, much of that will be about staffing and the kind of the need for that to implement the kind of models that we're talking about in option 1, 2, and 3. So there is a big difference between options 1, 2, and 3. And that's because we require more of the staff, and that's before I meant there would be a question over is it achievable to bring those staff in? That would need to be tested.
Okay.
Sorry, yes, and it was in relation to the estimated cost. Is that ring fence funding, specific funding for this, or is it something that we have to find in terms of the general pot?
We have to find, don't we, within our general.
There will be a consequence for our planning next year, but we will need to find this.
Andrew.
Yeah, thank you. And I just want to start by saying, as several have, but thank you to Marcus and Catherine and Nick for their service and clinical and operational leadership of this. Colleagues from RS for the excellent support they've given, and to Yvette as well from these team for the way they've supported the team in working through what's obviously a complex and difficult and sensitive issue. Obviously, as the Executive Director of Operations, I sort of feel I need to come in and give a view to you in terms of the operational deliverability of these options, and to some extent, Catherine has probably far better than me summarised some of where I would be going in terms of my consideration on this. So I think if part of the reason for wanting for the consultation and wanting to resolve some of the service model issues are around certainty of the model in terms of it being robust, it being available, us not having to go through repeated unplanned closures because of workforce fragility, which are all parts of the case for change. Purely from an operational perspective, as you work through the 3 options, 1, 2, 3, there are increasing levels of workforce requirement needed to deliver those options. Therefore, by definition, the risk associated with being able to fulfil those workforce requirements increases, and therefore potentially in deciding on an option, we build in a level of uncertainty for the population and for the service in terms of what we're trying to deliver. And I think there are risks with that, both in terms of we could end up back having to have another conversation like this in the not too distant future, because we've still got an unsustainable model that doesn't have the robustness it requires. But also I'm concerned about the risk from any confusion that would pose to the public and the population in terms of how they access services. I think the messages we've had around clarity are really, really important in this space. So I would just say that really, I think as we work through the options, we just need to be mindful they become more and more challenging to deliver. Certainty of an option would help because we will be working towards that and we'll know what we're pushing for, but they become more challenging to deliver as you add more service requirement and workforce need into that picture.
Yeah, thank you, it's helpful, Andrew. Helen, do you want to come back in?
No, Andrew's explained it better than I would probably.
Right, I'm now going to see if Lee, then Phil, and I want to add anything, and I'm going to bring in Chief Executive. Lee, anything you want to add?
I don't think so, I think the discussion's covered it all from my perspective.
Okay, thank you. Phil, anything to add?
Yeah, well, only to say is you can flash up and end up saying what you're about to say, Steve, so be careful. What should I say?
This is an unusual situation.
I suppose what I draw out then, there's a few things I would draw out of. One is that I think the transport is a really big point here, that I think when we implement this, whichever decision we make, we need a work stream that looks at that and engages service users. So we've really heard that strongly from the public. I think the point about clarity, the concerns over having a model that is unlikely to have unplanned closures is really important from a safety point of view. And I think that is something that's come out very strongly from all the work that we've done and our discussions today.
Okay.
I'll stop there.
Thank you.
over to you, Steve, for your word.
Thanks. Well, firstly, I just wanted to thank the teams, our clinical colleagues, our colleagues from ORS, our managers, for what has been a really diligent piece of work. And also, let's thank the board. We've discussed this a number of times now, but the quality of questioning, the thinking about this issue, I think is really important to do, and to do in public, given the level of public concern there's been. I was sort of scribbling down and also being a little reflective as the conversation was going on about the fact that when I started here in Hywel Dda in January 2015, that service change that happened 6 months before was still very raw. There was still a lot of consequences, and actually 9 years later, here we are. I think with the best chance possible of being able to now settle what we're going to be doing in the intervening years before we hopefully get to build our new hospital, which will bring all these services together in a better location for all of our population. So having sort of listened to the discussion, we find ourselves as the ones who are on the pitch who have to make this decision to take the next step forward. And that's a big responsibility for all of us, and I know it's one that we all take great stock by. Having listened to it all, I think I'm going to propose which option that I think we should be going for, to test with you whether I've heard what you've said properly, because in the end we need to come out of this today with the option in place so that the team can then get on and build what's going to be a really important next step. And for me, I think it came down to the interplay of the table of risks that was shown earlier on with the options scoring numbers, which is needing to strike the right balance between sustainability, reliability, robustness, I think, was talked about by our clinical colleagues, and ensure that our precious resources, and I don't mean money, although money is of course something for us to think about, I mean our precious clinical resources are used to the very best effect that they can for our local population, wherever that may be. So I think certainty of an option is important, but also an option that gives certainty is probably just as important. On reflection with all of them, whilst recognising that this wasn't the most supported option, it would seem to me the board should consider option one as the way forward, to start to put this service onto a sound footing. It is probably fair to say the least liked by the public, and we have spent time reflecting personally and together in a number of forums about what the public have said. But I think that the comment about it's better than what was there is also quite important, and does change the narrative around this subject for people with Pembrokeshire. I think the clinical voice we've heard today, particularly around that reliability and robustness, I've had stories about, and this wasn't in our health board actually, but in other parts of Wales that have faced similar challenges where a child has been taken to the wrong bit of service, and that can be really significant for their ongoing care. So having that reliability and certainty and clear-cut model, I think, is really important in that moment when people are at their most vulnerable in the moment of crisis. And also hearing from Andrew, the operational voice, underlining that and ensuring that we have a system that is not confused for the public and people can go to the right place first. Clearly, if we go down that option, there are a few things that, as we rehearsed at the beginning of this session, we absolutely need to make sure we are doing the best by, and that will particularly link to accessibility and transport. There are particular needs, I think, for this group of patients that we serve and their families, that we need to ensure that we strain every sinew to ensure that people get access. Not just those who find themselves being able to get through the system, but those who we should be concerned about who choose not to access at all because of the challenges we've got to those people. But with those in mind, those issues in mind, and wanting to bring that plan back in January about how we're going to address those issues, I would recommend to the board that we look to option one.
Thank you very much, Steve. Okay, I'm going to draw the discussion to a conclusion now. As I said, we're going to take a break. We have taken quite a long time on this issue, but I think for all the reasons we know it's so important to do that. So I'm going to suggest we take a 10-minute break. There is tea and coffee available there, and also some cakes, courtesy of Lisa, and some mince pies from both of us. So please help yourself. And Thank you, everybody. Okay, so thank you everyone for coming back swiftly. And as indicated, I'm now going to go through the recommendations on the SBAR, which is on page 18. I also want to again record my thanks to all of the staff from the paediatric team, and particularly for Marcus, Catherine and Nick, who are here today, and also to Yvonne, who has helped so much in taking through the process, and any other members of the team who aren't here, and also to our ORS colleagues. So the first recommendation is to note the Best Practice Quality Assurance Certificate achieved from the Consultation Institute, which I think we have done. To consider the summary of changes that have occurred within the service since 2014 and the challenges that led to the requirement for these changes. These are all detailed on page 5 and 6 in the SBAR, and I think we have considered them. Consider how the options were scored as part of the options development process, and the way, and we have done that, and also the way the engagement and the consultation of has been handled, involving children, parents, carers, staff and the wider public. Number 4 is consider the key findings from the consultation feedback report. I think we have done that. Oh, excuse me. And we've questioned a lot of those details very thoroughly. Recommendation 5 is consider the findings of the stakeholder review of the alternative options. We have done that, I believe, and also the issues raised in relation to the services currently in Glangwili and the issue of training, and I will come back to that. You're content so far? That's good. Go to recommendation 6, which is to consider the findings of the conscientious consideration process. I am actually going to read out what some of those key themes were. It was the lack of awareness of the dedicated ambulance vehicle, which we have explored. Better signposting around the referral process into PACU for public and staff. The environment in Glangwili at A&E and its appropriateness for children. General travel, transport and accessibility, and the sustainability issue of staffing, financial and operational. And also the RARC issues at Withybush, which we've not gone into in detail, but the board has had previous reports in some detail of the impact of that situation. The 7th recommendation is to agree a preferred option for how the health board provides urgent and emergency children and young people services at Withybush and Glangwili. We've talked here about the case for change, and we've also talked about how services should be configured in a safe and effective and sustainable way as possible, and on the basis of giving certainty to both the staff and the public, as described by the Chief Executive Officer, and proposing that we do conclude that option 1 is the preferred option. The board content with that decision. Thank you. Number 8 is to note the development of the EHIA for the preferred option, which will now take place for option 1. And to finally note the requirement for the service to develop an implementation plan. I think we've already highlighted that that should include the workforce, accessibility and transport issue, the digital agenda, the involvement of primary care, particularly GPs, to include the issues that have been raised within Glanmilly, and also a communication plan, both on the decision but also going forward on how that will be implemented. Is everybody content with that final? Okay, thank you. So thank you everybody. I know our colleagues from paediatrics are going now, leaving us. I know this is not the end. This is obviously still a challenge, but you have the support of the board to take forward this option, and we look forward to receiving the plan for the implementation plan, probably in our January board, but that is something we'll discuss outside. So thank you all very much, and thank you everybody else.
Thank you.
Okay, so now I just need to swap files, bear with me, and we'll move on to the next item on the agenda, which is an update on the annual plan, and that's you.
Thank you, Chair. And obviously, I know we are pushed for time now, so I'll be brief. And hopefully the paper is quite self-explanatory. We're at a point in the year where we're obviously a good way through our existing plan and considering what we are going to achieve between now and the end of the year, and we're also then starting to turn our thoughts to development of next year's plan. So the paper provides an update on our expectations on the delivery against each of the planning objectives, and in particular the specific actions within the planning objectives following the discussion we had at the September board meeting, which members will remember. You'll note from the summary that we got there, the detailed summary, that most actions, the majority of actions, are either complete or ahead. We obviously got 2/3 of the way through the year, or on track. But there are some where reflecting either challenges earlier in the year or our refocusing and greater attention on the in-year savings delivery has meant we've had to moderate some of those expectations. So what I would say is, and the paper does pick this up, the impetus we put behind core delivery group establishment and the focus on those savings has borne some fruit, and that's set out in the financial report in more detail subsequent to this. Although it is very clear that we still have a very long way to go, and this is more about just establishing a way of working which hopefully will continue to deliver some of those results into the future. The work has commenced on the planning for next year. The paper outlines some expectations around that, what we understand the task to be and the requirements, and it also references the establishment of a new executive planning steering group, which works in partnership, if you like, with the core delivery group to oversee the plans for the next financial year, and then obviously they will transition into the critical work programs for the core delivery group for next year. So the two sit together. That's always been a cover, Chair. Thank
you very much. Questions, Maynard?
Yeah, it's two things. First of all, thanks for the paper, really useful. So good to see you things. Given the some of the actions are behind and some of the flag on track, is on track, are we confident of delivering against our plan by the end of the financial year? And the second question is about next year's plan, about how we are getting a wider involvement in that planning process in terms of involving lower levels of the organisation, feeding through good ideas and things into plan objectives and plan.
Yeah, happy to. I guess so. On the first question, where we've got that the action is as per plan or expecting to be completed in Q3, Q4, then yes, you can take from that we're expecting to be able to deliver that, and that's sort of refreshed, revised position. You'll note obviously that some have been paused, and naturally that means that we don't expect to deliver those. there are a number of components to our plan. So there's the financial plan, which we'll talk through in detail shortly, and then obviously the performance deliverables, which is a more mixed position, but that'll be covered through the IPAR in detail as well. But as far as the planning objectives are concerned, the summary you have in front of you is the state of play as we see it today. On the development of the plan for next year, I think what we've seen through the core delivery group and through a lot of the work that was done during the summer was this more of a connection, I suppose, with the next couple of tiers of management structure within the organisation, and that's allowed us to properly understand what true options we might have and the implications of those options if we were to make changes. So that work that was done in the summer and has been shared with board members has really given us a really robust baseline which we're going to then develop and iterate from. I think so through the development of the plan and through our directly moving together sessions and so on, that will continue, and we'll use core delivery group and Palexia group to do that. So I think we can probably be fairly confident that we will have that level of engagement with the senior levels of the organisation, if you like. I think as part of our wider rollout of director and putting together methodologies, right down to a service and ward or department at that level, I'd probably reflect that still work in progress as we put in my position on it. I think that's something for us to consider as we develop our plans or implement our plans over elements as well.
Yeah, thanks Steve for a really clear paper. Just want to focus on the financial thing which you've accepted, of course. So the first thing, in terms of the current year, I'm just going to check on our progress with savings and to what extent is our expectation of savings ongoing. First and ongoing, I can see a lot of progress being made to closing the gap. And secondly, just still the theme of savings, looking at the plan side for 24-25, what expectations have we had of directorates and also corporate departments around the savings that we're expecting to make? And my reason for asking that is obviously we need to move close to medium-term financial balance, and therefore we need to put some expectations in place now for the future.
Richard, I'm happy to pick up those two questions. Currently, our most recent assessment of the recurrent and non-recurrent nature of savings gives us a recurrent gap of 10 million. And so as we sit here now and look at the underlying deficit going into next year, it moves from a year-end outturn position currently forecasts of the order of 70-71 million to something that is slightly in excess of 90 million. So there is a deterioration in the underlying deficit that we are seeing and will be looking at as part of the planning cycle. In terms of your point around savings, I think there is a sense in which the opportunities aren't necessarily consistently felt across the organisation. So we need to have an element of opportunities that are quite focused into areas where we know there is a high level of, let's say, agency usage, which is driving a significant cost burden for us. But there is also a generic requirement for improvements and efficiencies that we would expect to see across the whole organisation. We'll bring more of that back as part of the planning cycle, and we'll explore it through a board seminar session that we've got coming up in December as well.
Yeah, I think where I'm going with this is about, I think I'm really clear around this table that we know what the expectations are for savings, but I think how we translate that to the next tier down is going to be really, really important. And that's why I talk about setting a degree of expectation that alongside service development or cost pressures that we support, there also has to be some efficiencies, because you'll see later on there's some business cases, the consultation that we've had around paediatrics, they're going to create cost pressures. So in order for us to enable those developments to happen, we also need to expect that we start to cut back on some of the areas of waste if we can, or some of the areas where we could spend things differently. I think that's really what we've got. And the earlier that we put that expectation in place, the better.
So you'll make sure we cover that up in the board seminar.
Chair, I'll bring that up in the board seminar. We've got a good session on finance book with that, so we'll talk about it.
Thank you. Hannah.
Thanks, Chair. Just looking at the detail in the appendix, I noticed that quite a lot of the plans that are paused or slowed or delayed relate in some shape or form to staff experience, well-being, and that kind of staff satisfaction, if you like. Have we assessed the consequences of slowing down on initiatives that are about trying to attract and retain and help our staff to maintain a good working experience? Is there a risk that some of this is perhaps, dare I say, a little short-sighted?
So just to comment on that, some of the ones that are paused within the workforce one are actually embedded into normal practice now, but we have to accept that this is a consequence of the financial challenge. So as posts are, as people leave within the functions, they're not being replaced at the moment. So to manage that financial position, we're carrying a significant level of vacancies in the workforce and LD team, which means we're having to prioritise where we put our efforts. And at the moment, that's in the workforce effectiveness piece around supporting the financial position. So some of those, therefore, we will focus on the ones that we absolutely have to do. The ones that we really wanted to do are just going to have to wait until we're in a position where we can continue to pick that up. We are still seeing a reduction in turnover, so we're still working through the retention programmes. We're still working with our trade union reps in terms of the non-pay elements of the pay deal. So all the key things are still being progressed, but some of the things that we wanted to do, we just slow down.
So have we weighed up the risk of proceeding with filling vacancies that are currently on hold with the risk of failing to tackle staff experience, staff satisfaction and so on, which clearly has an onward cost for us in terms of recruitment, agency use, etc., etc.
Absolutely, we look at it through our risk register. So we know we've got ones about staff experience. We've got one that's been added recently now about the pressures for our workforce. So just having to manage it as we go along. But the OD teams and the workforce teams are still doing all they can around the staff experience on our disciplinary grievances. We have a large number of cases. We're working on informally, we're focusing our efforts on all of those things that will support individuals.
So we're still confident that this is the lesser of two evils. Yes. Okay, thank you.
Yes, if I can just come in on that point, because I think it's a really important point, but I do think that it's important that we recognise we don't simply rely on the OD team to assist us in terms of some of these issues. And all of us in our own senior management teams and with that cascading down into our teams do those checks with our colleagues in terms of how people are feeling, what their experience is currently in terms of managing the significant pressures that they're facing, and also being available, to be honest, in terms of dealing with any cases that do escalate up to us, but making sure that we've got the right processes in place throughout our teams that can help with experience, but also deal with any concerns as quickly as possible. I think that's something that, with the help of Lisa's team over the years, we've all been developing, but I think it's something that, particularly at this point in time, we pay due regard to, and we certainly do that.
Okay. Thank you, Given my point, actually, because presumably this is about developing managers to behave like this with their workforce and not rely on your team to do it for them, but to be there to support, particularly as we come into a good point to make. Thank you, John. Okay, so if there are no more questions, recommendation is on page 4. Is people content with that recommendation? Okay, thank you, Lee. So I'll move us on now to the financial report, item 3.3.
Dr. David, thank you. I'd just like to take the board through the latest financial position and recognising some of the changes that have happened since we last met, but also re-emphasise the challenges that we're facing in our finances and the consequences that will have on our cash position and how we maintain the delivery of services through that. Since our last board meeting, we submitted an accountable officer letter to Welsh Government indicating that our forecast deficit for the year would be £128 million. On the same day, coincidentally, that we sent in that letter on the 20th of October, Welsh Government confirmed that we'd received an additional £56.8 million of additional funding. That funding is conditionally recurrent. The basis of that means that if we are able to achieve our control total, the intention would be to make that funding recurrent, and if not, then it may not be repeated in future years. So there is a degree of risk to us in the continuation of that funding. They also confirmed that any underspend of COVID ring fence funding would be recovered and provided us with a control total that required us to go further than our original plan by £11.3 million. Naturally, I'm grateful to colleagues in government for providing the clarity and the additional funding, and it is incumbent on us to respond with an improvement in our position over the coming months, and we are committed and focused on that as an executive team. Nonetheless, as I've outlined on pages 3 and 4 of the presentation, our control total is £44.8 million deficit at this point in time, and our current forecast after working through all the new funding announcements is 72.7. I think I misquoted earlier when I mentioned our deficit. So 72.7 million is our current projection, which gives us a £27.9 million gap to the control total. On page 5, closing this gap would now require a £7 million improvement in our run rate from December onwards. And of course, there's no winter funding likely to come through, so maintaining our trajectory would require tight operational controls to manage surge over that winter period. The gap last month against our plan was £25.5 million, and I just want to explain what's shifted. It's improved by £3.4 million, which I outline on the right of the page, which is the result of operational variations, notably pathology, oncology, unscheduled care and planned care drug spend has driven some of that improvement. CHC has also improved by £0.4 million, and primary care improved by £1.5 million, but that's mainly the result of dental contract underperformance. So it's not an area of underspend we would want to see as a board, and that was partly then offset by a continued deterioration in medical staffing issues. There has conversely been slippage on mental health CHC savings. So despite that overall improvement in CHC, mental health CHC's position has deteriorated because the savings scheme has slipped, and the impact of that's at about £500,000. And we've identified other savings schemes to the tune of about £6 million over the month, which is a great achievement. Sorry. Okay, no, that's fine. So we will come back with more analysis on the recurrent nature, just to answer your question from earlier, Winston, but broadly, I think the quantums tally with what I mentioned earlier. Page 8, our savings performance forecast delivery against the 18.9 million remains a challenge. In particular, deliveries behind by about 4.3 million. £500,000 of that relates to our work on flows. 3.8 million relates to a combination of nurse stabilisation issues where fill rates have increased and eroded the benefit. Interestingly, the benefit go with increased fill rates has cost us year on year about £7.7 million. So had we kept our fill rates where they were last year, we'd be 7.7 million better off at this point in time. Now that clearly has a really good impact on quality that we're able to provide with those improved fill rates. So I think it's worth noting that. If I then move on to page 15 and just pick up where we are in our forecast. The forecast position on the right-hand side by service portfolio is dominated by the Carmarthenshire and Ceredigion systems. Good to know that oncology is now broadly balanced after we've allocated non-recurrent planned care recovery funding into oncology to recognise the pressures that were being experienced in that directorate. Pembrokeshire's forecast has improved significantly over the year, worth noting that. So they were overspent by 1.2 million in the year to date, but able to limit that to 1.5 million for the year end. So that indicates an improving trajectory for the year. We also had similar improvements in women's and children's, which is very positive, and I know some hard work done there on rotas in particular. The issue now is around how we manage the other counties and how we make sure that we mitigate the pressures of winter on the system more broadly. On page 16, some interesting positions to pick up here, Chair. Our whole-time equivalent worked position, so the top left-hand chart, is now at the highest level we've ever experienced, even during the pandemic. And that's largely, but not exclusively, driven by some of the work being done on this recruitment. And that's making its way into the top right-hand side, nursing agency. We're now down to levels of whole-time equivalents we've seen back in June of 22. And again, that impact of fill rates has been covered off and mitigated as part of that. But our spend has improved on the bottom right hand by even more than the whole time equivalent improvement of agency. And we're now down to levels of agency spend not seen since 2021, with a further improvement in month 8. I think the indications are there's another 0.2 million improvement in month 8. So very positive work has been done there. And that takes us down to a pre-COVID baseline level, which is good to note. But on the bottom left-hand chart, that impact is being eroded by medical locums, which has continued a steady increase. And if that spend is maintained into next year, I think that gives us a real pressure going into the next year. We're now spending the best part of £1 million more per month now than we were this time last year. So a very significant increase. On page 17 and 18, CHC medicines have all increased, but that's a continuation of a fairly expected trend and one that is driven by inflationary pressures that we're experiencing and we've captured in previous reports. Nothing new particularly there. Interesting, I think our benchmarking suggested limited opportunities to improve in those two areas. We will carry on focusing on improvement, but I think the main drive needs to be on thinking about our workforce and how we stabilise the use of agency. And on page 19, I've just included some reference to the work that's been done through the core delivery group, and thank Lisa, Dr. Workhorse, for leadership and sharing of that group. And you can see the impact that it's had in the bottom left hand, and then the areas of focus for the next few months on the bottom right hand. One omission from the work plan is radiology, and we've already seen a plan which suggests a notable improvement in the use of agency in radiology, largely removing that by the end of January or else being equal, which is very positive. A very challenging position. There are actions being taken by executives to recover that, but clearly this is not the position that I would want to present. And I do want to give assurance that we are actively monitoring cash implications of that position.
Thank you. Thank you. Right, open up for questions. Any questions? Yes, Steve.
So yeah, I think on page 19 is quite helpfully set out the next steps and mitigating actions in the report, which I think is really, really helpful. And we also set out what's been delivered, and I can see that there are some green shoots on what we're doing in terms of that financial recovery plan. In terms of the further work plan and deep dives, it'd be helpful to just get some timescales around some of these as well, because it's great that we've now, I can see that there's ownership across the executive team. But for example, if we're looking at important areas such as the annual open review of services, it'd be good to know what that looks like, or another one. So I'm not just speaking of one director. Configuration of the mental health section 136 unit. We just need to just get a sense of that. Also, another point on that is that seems to be an awful lot sitting in Andrew Carruthers' remit as well. So, given with winter and other things happening, I just want to be assured that you've got the right support and capacity in there to enable you to be as successful as you can in terms of those further work plan deep dives.
Sure. In terms of detail, we can bring that back to Sustainable Resources Committee in December, and we'll bring that back in a measured report to show June, December about support. Sorry, see you there.
Yeah, sorry, I was just going to add, we have got a detailed timeline between now and mid-January for each of these schemes to come back in. So they are all very much managed and controlled through the CDG group, so we'll share that timeline with everyone.
Thank you. Andrew, did you want to come up here?
Yeah, no, thanks for the question, Winston. I think there's a number of these areas kind of fall within work we were progressing anyway. I think there is something around us being really clear on this list around what we can go at that will materially impact the position between now and the end of the year. I think that's still some of the work we're working through with the core delivery group and the services to really understand, because in some cases, so whilst in over a medium, let's say into next year, we could possibly see some cash benefit. In the short term, it might be more in the cost avoidance supporting space, and in some cases, my nervousness is that they may require a degree of investment. So that's what we're trying to work through at the moment, is to understand how all of that balances off in terms of a plan for the rest of this year. But we've got through the core delivery group process a really clear programme timetable now of updates on all of these schemes going back. All the services are attending that forum as well to provide updates and feedback in terms of where they are just generally in their local management of this issue, and further actions and options they're developing. So I think, as Hugh says, we can probably bring something more back through Sustainable Resource Committee that answers that question for you.
I think if we'll get that assurance there, I think just for the board, I think is quite important. And the reason why it's important for the board is that when you get the different ways of the core scheme, so interesting quality and safety, impact and performance and other things. Whereas in SRC, I'm not just going to be interested in the money coming out, really, to be honest. I just wanted to just check as well, in terms of the support question I asked, was in relation to not only do you have a service need, but also the financial support and also kind of management support as well, because I think that's really quite important, given the kind of the size of your job. You're going to need all those things in place as well.
And though as part of the work and exploring what the opportunities are and what we're really going to get behind, that's all part of the conversation. Yes, there are finance leads identified. I've got people identified to lead on these projects at the moment to get to that point and be really clear around what the scope is and what we're then going to drive forward. And I think at that point we'll also need to have a further conversation potentially around what other support do we need to play into that work to get it over the line, because there may be elements of the quality improvement team that would benefit, some of those schemes would benefit for some of the digital transformation team in terms of virtual board kind of conversation. So there are various decisions I think we still have to make as we go through this process around support requirements.
Thank you. One quick question, Chair. I just want to know what comms are setting out now in terms of the progress we're making and the areas of challenge in relation to our service program. I think that's quite important that we hear that board.
I don't know, Lisa might be giving updates. I don't know where our one is not here today. She's not here.
Just lost her a second.
She's there. I didn't realise you were there.
She's there in the virtual world.
I am, and sorry for not being with you in the room. In terms of communications and supporting us throughout the journey, then we are looking at opportunities where we can highlight the efforts of our teams, and also through a series of videos for our staff, particularly looking at where people can help us to make a difference. So looking at things such as short and sharp videos with colleagues around where people can help in terms of things like making savings, or if it's around energy use. So for example, from next week, we will have a switch it off campaign starting that helps turn laptops off, for example, small things that people can contribute that adds to the work of the core delivery group and the financial delivery group, to try and explain that in a way that people can understand and can get on board. So there's a number of things that we have planned, and equally then working to highlight some of the communication that's already come out from Welsh Government around how people can access services the most appropriate way. So it's a kind of a whole system approach. It will be something that continues over the months, and hopefully not years, but the time to come, to help share our progress, but also to ask and hopefully inform our public to access our services and support us through this difficult time.
Thank you.
Just briefly on that, because I think it's important. So the comms have been built in from the beginning of this process, through, as we set up CDG, and recognising the particular role of SRC and some of this. Of course, as a board, when we signed off the process, we also signed off that for all of our decisions, they would go through the quality impact assessment and the quality assessment process. So just to reassure the board that for all of these decisions, they are all subject to those arrangements as well.
Yeah, thanks, Chair. On page 19, the section that we referenced there, I noticed huge about the situation in Pembrokeshire and the improvements seen was there, and a large chunk of that is down to this 39 bed reduction in Pembrokeshire. Partly driven by that, or partly driven by the work that we did before. And two questions. One is, how do we ensure we keep those beds out of the system with winter pressures coming on? And secondly, how do we learn from what's been done in Pembrokeshire and roll it out to other parts of the health board that can really keep us forward and progress?
Okay, thanks, mate. I'm conscious Jill may want to chip in as well on this as I'm going through the answer, but I think so. There's a very stated desire from the system in Pembrokeshire across community and community that they don't want to put those beds back into the system because they believe the model they've got on the reduced number is the right model, and they continue to drive improvement. And there's obviously a risk to that going into winter, and we'll have to keep a close and watchful eye on that. But that's certainly they're very clear. I was with Angela Puffett, who's been really key in leading this on Monday, and she was again reasserting that they don't want to go back, and there's a clinical consensus on that in Withybush. They don't want to go back to having those medical beds back in the systems. A lot of those were surge beds that they didn't have stuff for. So I think there's a real commitment to that model. I would need to hire. So then, in terms of answering the second part of the question, I've got to be really clear that work has been ongoing for over a year now in Pembrokeshire. It started in at this time of sort of October 2022 that they first started that conversation. It was born out of a really very engaged clinical response to some of the challenges they were facing going into the winter, and they really, as I said, Angela, really driven that with her colleagues' support to change the model. Lifting that then, when that's been such an organic process, to lift that and just impose it somewhere is then quite challenging to do in a short period of time. But all of the other systems have been down to Pembrokeshire to have a look at what they've done, and all of them are taking the learning from there back into their own local areas and developing their own plans. So Carmarthenshire in the process of working through what the model in Pembrokeshire would look like in a Carmarthenshire context, and I'm anticipating that before Christmas we'll have, even if it's only high level, a clear view of milestones around the steps they would need to take, even if there are risks and obstacles to them doing that at this point, the steps that they would need to take to implement the same model or a similar model with the same benefits for the Carmarthenshire population.
Ceredigion are also doing that piece of work, but in their own analysis of what has happened in Pembrokeshire, they feel they've got a lot to do and benefit to gain from focusing on the review of their front door model and how they make that more efficient and effective, avoiding admission and attendance. So that's where their predominant focus is, because they haven't tended to have the same kind of discharge delays as some of the other counties have in the same volume. So that's how that's being approached, and those we're expecting the Ceredigion do as well, kind of early in the new year from the work that they're doing that they reported in our recent improvement together session. So there is work ongoing.
It's good to hear is that we're not trying to do just a lift and shift. We are looking at individual circumstances. That's really good.
I don't know how it's coming, but I suppose, not to be harsh, but I suppose what goes through my mind is why weren't they doing it anyway? And why weren't they at the same position as Pembrokeshire? Because the establishment, the way the systems work, well, not the systems work, but the way it was organised was the same. So if something has moved it in Pembrokeshire, and I suppose I'm looking for assurance that it just feels that they were thinking about doing things differently. And if I'm harsh, Carmarthenshire and Pembrokeshire and Ceredigion weren't, that's probably unfair. But I'm just wondering why now they're only just looking at what they could do.
So,
maybe it is unfair, but that's how it sounds.
no, I understand the question, maybe the way to phrase the answer. So it's not that they've only just started looking at the solution to the problem in Carmarthenshire. They've been looking at it through a different lens, and they've been very much focused on, in particular, how they, as Pembrokeshire, I mean, let's be clear, Pembrokeshire in the same place. They were very focused on how they sorted out the front door model, prevented people getting to hospital in the first place, avoided admission and turned them around as quick as possible, because we know, as we've reported before, once you stay past a few days, you're in a long time. So there's a real window of opportunity in the first 72 hours. They've been very focused on that. Pembrokeshire were focused on that in the same way. The issue that changed the dynamic for them very suddenly was a realisation that we weren't going to have 6 wards available to us within 3 weeks. So it was always the plan to go down this route, but it forced their hand, and they had, through the work we've done for COVID, they had capacity in South Pembrokeshire to create space to change the system. That's slightly different in Carmarthenshire because they don't have that flexibility in the community capacity they've got. So they're trying to bring all of that together.
Thank you. Anna.
Thanks, Sharon. And my question does sort of relate, I think, to what you've just asked, Jan. So I think, we're all so very aware around this table there's a risk we can normalise bad stuff happening. And whether we're talking about quality or we're talking about money, when week in, week out, month in, month out, we see a shortfall in standards, and in this context, it's about delivering our bottom line, we can get into a sort of a cycle of, well, what's the number this month? And one way to guard against that normalisation is to be really vigilant about what we can learn about the things we've tried and what that trying has produced, both in terms of success, but also in terms of things that haven't happened in the way that we predicted. So when we look at sort of, let's just take it in this 2-month board cycle, when we have a position and then we have, this is what we're going to do about it and this is what we predict the results to be. 2 months hence, when we then come to see how good our prediction was, how much time do we spend looking backwards to think, okay, so what was it in that 2 months that didn't go as we intended it to do, or equally what allowed us to deliver success, versus, okay, well, that's another 2 months gone, dust ourselves off, get on, let's look forward and try to do the next thing. In that balance between learn from experience versus let's just try something different, how well do you feel we strike that balance?
Gosh, these
Do you
questions.
want to answer that one, Steve?
I'm going to start with it, but everyone else gets their. I think it's a really interesting question. I think my initial response would be we probably spend more dealing with problems looking forward than we do looking back. And I think it's probably what you refer. It's partly, I think, just given the sheer scale and complexity and number of challenges that we face, that we're just on to the next thing. It's also partly the cultural thing. For organisations in the NHS and how are being parts of that. We did some time ago, what's sprung into my mind is we did have a discussion. We had a planning objective about becoming a learning organisation. How do we capture genuine learning from not from mistakes or errors or sort of clinical individual clinical incidents, but in what we try to do as a board and whether it works or not. So probably we need to give a bit more thought to. I'm trying not to look at the director of governance because it was sat with her. We did step it down a while ago for all sorts of reasons, but it's probably something we ought to dust off and think about, because there are lessons to be learned from what have been some really significant changes to our system, some during the pandemic and some since then, partly as a consequence of the pandemic. I'm not sure that we use that learning either for our own benefit or indeed for the rest of Wales' benefit in a structured way. I'm sure it happens to some degree. I don't think we do it in a structured way.
Sorry, Lisa.
Okay, so just talking about some of the things that are on the programme here, I think we have really focused on learning. So the very first piece of learning we had as an executive team was the nurse stabilisation programme, whereby if we bring in 100 overseas nurses, we'll lose 100 agency workers, and we did not predict the increase in fill rate. So using that methodology, we've then gone through overseas recruitment for medics, and therefore how are we sure, if that is something that we're going to do, are we putting them in the right place so that we don't see that increase in roster requirements. The acute kidney paper that you will see that was on here, when it came to the CDG, we did not have enough information that said we have tested this out of the operational team and are the consequences properly noted. So before we rush into saying that this sounds good, do we understand it? We have now got a methodology whereby people know that plans initially go through to Andrew. Andrew's management team will go through the rigour of them. When Andrew is satisfied and his team, there's something to progress it then into the CDG. So they don't bypass anybody so that we miss out important pieces of information. Scheduled care was another key one, where when we drilled into that last week, actually there's a lot that was in the savings programme for the management team there that are outside of their control. Because actually we need to understand what's in our service delivery plan. Because if we're not going to change any service delivery things, we can't expect that management team to make changes. So we're separating out what are the things that were in the plan for scheduled care that is within their control and they can manage, and which things aren't, and therefore we look at how we manage them separately. And the 100 virtual beds was another classic one that came, and through the rigour of the process actually was not robust enough to assure us that it wouldn't be increasing costs, impacting on quality and safety, impacting on a whole range of things. So again, it's gone back to say it needs to be further work, it needs to be for our operational teams who understand the delivery. So we absolutely are learning every single week with all of the papers that come, and I think because of that we are now seeing the rigour. So the radiology team, when they came to remove 15 agency workers through a robust plan that is not impacting on the service delivery, has been a significant achievement for the service. And medicines management, when they came this week, massive amount of work that's in that programme that is delivering better quality and financial savings for the organisation. So it's very much at the fore of our minds in each of our meetings.
Yeah. So you're going to do the same regular with the medical workers, because that's the medical locum,
overseas medical
work.
And the medical locum position is coming to CDG next week. We're looking at top 10. And we're going through we will be going through a robust process in terms of what can we recruit, what can we do in terms of rosters, what can we do in terms of issues, and then it becomes, is it a service issue and what do we need to do about it?
That's great, thank you. I think Lee wants to come in on that point, or is it?
Yeah, I think Lisa's covered most of what I was going to say. I guess just on Anna's point. So what Lisa's describing is we've developed a process now, a methodology, if you like, which takes us through an inquiry phase, which is where these ones are, and there was some sort of establish what the objective could be, and so on. Discovery, design, deliver, and the end of that is evaluate. So where a scheme progresses all the way through, we would want to have a formal evaluation process, likely through CDG, that would reflect on to what extent we've achieved the original objectives. I think part of your question, though, is there may be an opportunity for us to consider where proposals or ideas don't work their way all the way through, and because there are gateways as they move through stage, if you like, and what is our learning and reflections as to why that's occurred, and if there's something we can use for further schemes. And that might be something we want to, conversation was to have this exact, but whether we incorporate that into our CDG process so that we can sort of codify that learning then into future schemes and processes. So we're capturing it all somewhere. There's all these is actually accurately describing all the learning. I guess just on reflection request where we're holding that in our minds as opposed to it being embedded into a process. So there's probably something about that.
So I've got Hugh, Mandy, then Darren.
Yeah, thank you. And I was going to mention many things that Lisa did, but if I just go back into the finance space, to a certain extent, we've been on a bit of a journey in finance to move from being backward looking to trying to be more forward looking and live in our forecasts. And one test we do every month is we forecast on a monthly basis to the end of the year. And in each monthly cycle, we go back and see what we forecast for this month and see how this month pans out in relation to that, and then learn from that. So we have that process quite explicitly embedded in our approach. I guess the more general reflection is while we are learning constantly, we're probably not documenting that learning and formalising that learning. It is just becoming more embedded in the way in which we work, certainly through our core delivery group. One of the challenges I think we have is value and productivity, and recognising the benefit of value and productivity. It doesn't really improve the bottom line per se, but it would help us, I think, be more explicit about where we are putting in conscious actions to reduce demand on our services. And one reflection I've had, certainly going through this year, is that we budget on the basis of capacity. We budget for capacity, not for demand. And I think I want to reflect on that as we go into next year's budget cycle. The work that we've done on the long-term financial plan has shown quite a very clear trajectory for demand, but we'd never incorporate that within our in-year budget or our next year budget cycle. That's certainly something I want to pick up as part of the discussion we'll have next in December. Yeah.
Okay. Sorry, I should have said that coming up. Those answers coming up.
Yeah, I mean, I think there's slightly different takes on it, but all I think in a place where we're saying we are not yet unconsciously competent as a learning organisation, and therefore there is more that we can do to take those individual examples and embed them into the sort of the DNA of the way that we work. And I suppose that, for the outside world, a key test of their confidence in us is about our ability to predict what's going on in the spending of in the financial health of our organisation. We know that it's an art, not a science, but it is an art that every NHS organisation has been using for decades. And when each time we see a report that looks really quite different from the last one, it inevitably raises concerns about, are we really on top of understanding what's driving our financial health in this organisation? And until we get to a more stable place, even if that prediction is much worse than we would want it to be, I think there are some real questions that inevitably others are going to be asking of us as to how far we really understand the impact of all this activity that's going on. It's the impact question that feels important for us to really keep challenging ourselves.
Good. Right, I've got Mandy and Darren.
Yeah, really, it's just to sort of add, I suppose, and thinking about some of the discussions that we've been having about formalising the quality impact assessment process and mechanisms that we've got in place. Because when we're thinking about learning, yes, it's learning from things that we've already done, but actually by formalising the process and integrating it much more with the financial aspects and the performance aspects, so that we understand what are we measuring, how are we capturing it, and how are we feeding it into our other mechanisms and meetings that we've got. So are we looking at leading indicators that tell us not just is what the service expected to happen as a consequence of that change, is it materialising through the metrics that we're monitoring, but actually how do we learn at a really quick opportunity to stop doing what we thought was a good idea and actually take corrective action at an early enough stage. So the leading indicators really tell us that. And I think by then making sure that the reporting mechanisms through both the CDG, the control group, looking at how it feeds into our Directorate Improving Together meetings so that we can follow it up and monitor and track in a much easier way, and then looking at how we report and summarise that through our Quality Safety Experience Committee has got to be a way forward, but it is going to need a cultural mindset and change in recognising that the sign-off through the clinical executive has got to be key in ensuring that whilst we focus on the money, we focus on the performance, we're also understanding the quality that's driving through the entirety of our processes and decision making. So just wanted to put that on. As usual, Mandy has stolen my thunder in a bit, but I think we do need to formalise the way that we capture the learning from our QI projects, because Chair, you and I have attended a number of these, and they are big gains financially, but big gains on the quality aspect. And I think we just need to really capture that learning and enthuse our staff, because actually there is so much good work going on. So Mandy's obviously articulated it in a lot better way, but I don't think we've actually got it in enough of a formal way to capture that.
Yeah. And there was another event recently where we heard that, and they are now looking at financial benefits to all of those. Okay,
just a quick one on this one. Is there a mechanism within the organisation as to how you disseminate the information in terms of the learning? Is there a kind of formal way of how we, bring it in through so that every member working within the organisation is aware of all of those changes and the positive impact of those changes?
I think probably I've always said that if ever we purposely and I patent the idea and I person, I think the variety of mechanisms that we've got are going to continue to be essential because of the diverse workforce that we have. So we can't rely upon the medium that we've always relied on. We've got to think about new and innovative ways of sharing that learning. One of the things that we've been having a conversation about in the last fortnight is about how we publicise through the quality duty of quality requirements around always on reporting, so that learning change that we've made is actually translated into a report that's easy to read, easy to understand, is updated on a quarterly basis, and actually is for our public as much as it is for our staff. So watch this space. I'm not quite sure what it's going to look like, but I'm sure somebody to my right will be actively working on it in the first quarter.
Right. Thank you. So, recommendation is to note and discuss the report, which we have done. So, I'm going to move us on now to the next item, which is implementing Healthy in Mid and West Wales. Lee.
Yeah, thanks, Chair. I think this is a fairly straightforward update, so I'll be brief. It just gives a important business case. There's 5 key points to note in terms of the update. One is that we've received a draft of the clinical strategy review conducted by the Nuffield Trust, which, on our interpretation of it, is broadly supportive of the direction of travel that we've set out within that strategy, but we still await the final report. That has to go through Welsh Government processes, naturally. We've attended IIB, we did that just before the last board meeting, and we've subsequently received a letter from Nick Wood on that presentation, which we've also responded to, seeking clarity on a few other points, which I'm happy to take any questions on. Our PVC, as part of that IIB presentation and a subsequent letter, obviously it's still outstanding in the sense of endorsement from the Minister. As part of our response, we've sought some clarity on the process and the timelines for that endorsement through the Minister, and you'll note that the SOC is drafted as far as possible at this stage. We were intending initially to bring it to this board for approval, but obviously that's subject to that Welsh Government discussion and feedback following IIB. And we will likely need to amend it to reflect the Welsh Government's expectations following that letter that we've recently received. And then the final point is that as part of Welsh Government commissioned a programme gateway review in relation to the SOC, which has been completed, and four members noted there's an amber review against that. So happy to take any questions.
Okay, thank you. Any questions?
Comment.
Okay.
Question, I think he's been very polite to me. Finished the update and it was very accurate. But effectively, we are no further forward in the PBC than when we submitted it. We still have no approval and no timescale for approval. We've been asked to undertake significant number of work in the development of the SOC, hence it's not appearing on the agenda today. And all of this just serves to lock our delivery of our agreed strategy and for the next years.
That's fair.
I think that's actually on the additional work that's up. We don't really know yet the level of additional work because although we've been asked to set out further options, we don't really understand the depth that we need to go into with those options. So that could be a fairly rapid piece of work, or it could be a very significant piece of work. So until we get clarity on that, it's going to be difficult to know timelines for us as a board.
We haven't yet had a response to your response to Welsh Government. So that. Helen.
I just obviously they explained about a new hospital and things, and I was just wondering about the community hubs and stuff like that. I don't know if I've missed it in paperly, but if there's an update on that, Cross Arms and Llandudno and
so we take that through our capital subcommittee group, and we bring updates to the board for specific items as and when. So Cross Arms, for example, we're producing the full business case that we're still aiming for that to be completed by March. And then we've also given updates, Karen, for example, as well. So there's obviously a range of those. Llandudno we haven't made significant progress on of late, partly because the focus on black and the other category developments, but still remains an important priority for us.
Okay, thank you.
Welsh Government now, we know on Tuesday the 19th of December will be publishing their draft budget for 24-25. Do we have any indications that, once we have sight of the figures in terms of, and we know in terms of the deficit that they're predicting, will that kind of help our case in terms of the PBC, or will it kind of be perhaps a quite negative picture, do we think?
Well, from a capital availability point of view, we know that the NHS Wales is significantly constrained, and what is required across Wales is far in excess of what's likely to be available. We know that the current capital pot that exists within NHS Wales per year would be significantly depleted if that was the source for our proposal. So that's the affordability challenge that Welsh Government are contending with. That said, the question, I guess, remains whether that is the source for the funding or whether there is an alternative means. I think we've been keen to stress through IIB and through our response in the letter that we have two hospitals that are essentially at end of life. So we've got one that's 50 years old, full of RAC, and another one that's over 70 years old. There's not really an option to not deal with that. So whichever way we go down, there's going to be a significant amount of cost, whether that's trying to keep the existing buildings going for however long they can, or whether it's the route that we proposed. So what we're keen to get across is that there's that challenge of affordability remains whatever course of action we take. So the question is what is the best way of dealing with that? And certainly our advice and recommendation on that is, rather than spending money on two hospitals that we want to replace and we can't significantly extend their lifespan anyway, better to progress with the strategy as quickly as we can. But clearly that doesn't remove the affordability challenge for us.
Can I just ask one point of clarity? In relation to the Luffield review, I know it's the Welsh Government's review.
Yes.
Do we have any idea whether that we are able to finish that at any stage for local population?
Sorry, Lee, we don't see permission from Welsh Government because it's their report, so we haven't got.
So we haven't got permission from them to do that.
Well, we haven't got that permission at this point, but we agreed that from the outset that was our expectation,
Okay.
and we've reinforced that in that.
So we're still
So we do, unless we're told otherwise, our intention would be for it to be shared with them.
Yes, but we can't do that.
It's not our due, it's not there for why we'd have to seek permission to release their
Okay.
Okay.
Okay, thank you. So the recommendations on this paper, thank you, Lee, are on page 3. We're content with those. Thank you. So we're moving on to the improving patient experience, item 3.5. Mandy.
Sorry, people are struggling to hear. So
Okay.
if you can on the live stream, so if you can just speak up slightly.
Speak up, please, everybody.
I'll be loud. Okay, so thank you very much. I suppose I ought to start by saying it's been a privilege to
my breath. Sure, you want to say that?
No, I don't know. I do know. To have been able to have brought a report around patient experience to every board. Not every board does receive patient experience reports, but I think it's been really important that as a board we've listened and we've heard the feedback and the experience of people that we provide services to. And as a board, I think that reflects the fact that we really do put patients at the heart of everything that we do. And I think today the discussions that we've had, particularly around the paediatric place, have demonstrated that this is all about patients, our people and our population. So the report that you've got in front of you is for the period August to September 2023. I just want to call out a few things. I'm not going to go through the report in detail. I do want to just indicate that the patient charter is due to be updated, and there's been an awful lot of work and engagement that's gone on behind the scenes to enable that to happen. And the expectation is, it was going to be here for board today, but we haven't been able to finalise it in time, so it will come back in January. And you will recall earlier in this year, I believe it was, there have been a number of suggestions about things that could be enhanced within the charter, and the team have taken that on board. I'm always amazed that so many people take time to respond to the surveys that we issue. We've issued 41,000 surveys just through FFT in the last period. We've had 6,450 people respond. That is no mean feat, particularly as I'm sure if you feel like I do, we've got surveyitis. And if you DPD deliveries, every deliveries, and there are other companies in Wales as well. Every time you get a delivery, you're asked to comment, and every time you come into contact with health services, you are encouraged and given the opportunity to provide us with feedback. However, what I would say is that despite all the noise and the tragedies that happen within the NHS, and we're not without those difficulties ourselves within Hywel Dda, 92% of the respondents, so 92% of 6,450 people, have said that our services are rated good or very good. So that's always positive. And likewise, in addition, 1,600 people have also commented back. So an 80% plus positivity rate as well. But because we take a very balanced view, we also present to you the issues where we can do more and we can do better. One of the things that my team know is a great disappointment to me, and they had promised me that they would sort it out by the time I retired at the end of this month, is the response rate. So we've dropped down to 58%. It's the first time we've dropped down to that level for a number of months. In fact, I think when I first arrived, it was at 32%. We got up to 70, but couldn't maintain and sustain it. Why is that important? It's because we want to make sure that people who complain within this organisation have a timely response. There's nothing worse than people having to wait for an inordinate length of time, and we have half the time that it takes for us to respond to the majority of people that complain, are caused to complain. One of the key themes, and it's been something that I've talked about on a number of occasions here, has been about communication. We have got a more detailed conversation taking place at Quality Committee on the 4th of December, and that will be focused very much about the very broad range of activities covering the entirety of our workforce. It's been quite a complex piece of work and it is not complete yet, but I think it will give us a good opportunity to scrutinise that work. So again, that will, I have no doubt, lead to more opportunities for us. The other thing that I just want to call out is the kindness of Seren and her father Roger, who on page 21 and 49 of the report, you'll see a link there. It's very timely because it's Sensory Awareness Month this month, and we have Carers' Rights Day as well. We've also had some communication in from the Ombudsman's Office about sensory equality and equity of access associated with sensory impairment as well. So this is a really, really relevant story. And if you haven't read it and clicked onto it already, I urge that you do. There is help out there, and it's our job not just to look after the patients that come into our services, but actually the carers as well. And this story gave the evidence of a 9-year-old who was caring for her family, at times seemingly at detriment to her own opportunity to grow up and have a healthy young life. The other thing I just want to call out in the report is you'll know that I've had lots of challenge about whether are you really covering all the services with the feedback that you get. Well, hopefully in this report you can see that we've covered off primary care, mental health services, sexual health services, feedback from RAC, paediatrics, which I think gives us a fairly good innings, as well as all the acute services as well. Lots for us to do, we're not perfect, but one thing I would like to say is that just finally is the work of the Arts in Health team. I know I mention them every time, but I think that they are an area that provides significant benefit, not just to our inpatients, not just to our wider community, but to our staff as well. And I note that our new Vice Chair is a fellow in the arts. So I'm really expecting there to be further engagement in that agenda as well. So I'm happy to take any questions because I'm sure there will be some.
Mandy, thank you and well done for getting through that. And before I open it out, because I've been here slightly longer than you, I remember this at first, so I've seen it through all its iterations. It has got slimmer and more informative than what I remember at first. So it's a really, really impressive report. So thank you for the leadership you're providing in getting it as far as it has. Okay, questions? Anybody wants to raise anything? No? Oh gosh. Go on. I was going to say that you stunned everybody.
Recognising all your work, Mandy, and recognising the teams. I'm loath to ask this, but I have to ask it. Because I am really disappointed to see that there are 14 complaints about dignity and respect and the behaviour and attitude of medical staff. I am concerned about it, and whether or not this falls into the previous conversation about locum medical staff, I'm unsure if there is a trend or if there is a theme, but I am concerned. Yeah. And we have to really look at where this issue is coming from. And I'm sorry to bring that in, but we have to address it.
I've actually got it here in terms of one of the things that I'd planned on sort of indicating. So attitude and behaviour, we've got 5 from nursing, midwifery and health visiting, 14 from medical and 4 from reception and secretarial staff that relate directly to attitude and behaviour. I don't know how much of this is about locum staff. I think there are some issues that we need as a board to understand in terms of the context within which people are operating. That doesn't make any excuse whatsoever for poor attitude or behaviour, but the pressures and the pace at which people are working is quite significant. The environments of care that people are working in is far from acceptable in the majority of environments, particularly in our A&Es. And that does sometimes cause some tensions. But the work that we're doing around the making a difference, looking at how we can make sure. So I spoke last week or the week before to the new consultants on the new consultants programme about their responsibilities, about duty of quality, duty of candour, and actually identified that communication and the way they interact with patients is the one thing that is going to make the difference between a complaint and somebody's experience. And it's heartening to note that they acknowledge that. I think there's a piece of work that we need to do across all of our staff groups, because let's face it, our staff are the shop front of our organisation. And if one person has a poor experience or feels snapped at, or as in the report, the doctor called me a liar, that's one of the comments that has been fed back. Now, they may not have articulated it in that way, but it's how they make the patient feel. So always remembering the impact that your words have and how you say it, because you can sometimes have some very difficult conversations and not have that level of comeback. So I don't think there's a magic brush. We are all individuals, we're all individual personalities. And sometimes people don't always appreciate the impact that they're having on others. So rehearsing and replaying some of those experiences directly to individual members of staff is, I think, the way that we need to go. I don't know, Phil, whether you want to say anything.
Well, it's trying to move us to lunch. So okay, Michael and then James.
Yeah, thank you, Chair. Yes, my stomach is rumbling as well. It's a very good report, very, very helpful, and with a lot of assurance. I mean, don't want to dwell on complaints, but I mean, there's a figure somewhere there says about an increase of 73 on the last period. So, I mean, I'm relatively new to the board. How's that? I've got 2 quick questions. So the first one is, how does that set in the kind of context of trajectory overall for the kind of the year or something? So how does that look in trajectory wise?
Yeah, so 73 were managed as early resolutions, which is we want to see more and more early resolutions. What we tend to find is that the complaints in number they're very variable. Okay. 446 complaints that were received for the period. Not all of them progress through to a complaint that needs to be managed through PTR, putting things right, which is why the early resolution piece is so important. But it fluctuates by about 20, 30 each month, and there's no commonality in terms of the reasons why it goes up or down. Key areas that we get consistently higher number of complaints in A&Es, and that's consistent across all 4 of our sites, outpatients departments, and we've discussed that here before, and there is some further work, and again, the environment in which some of our outpatients are having to experience their services really doesn't help. So there's got to be some work done on that. So it does go up and down. We haven't got a trajectory per se of we're going to reduce complaints by 20%. The only trajectory I've got, or I've had, is actually if we treat patients well, we give them good information, then we would expect to see complaints reducing. If we suddenly had a big spike, then I would be asking some serious questions, and I would be interested in the theme that came back that was causing that questioning to come back, the complaints to come in. So not a trajectory as such, because whilst I'd love to say we'll have no complaints ever, that isn't a realism.
And can I just ask, Chair, just on complaints about complaints, because is that kind of captured in here? Because and what's the feedback on that? Because I'm talking about all kind of spheres of public services. Some people can get into a real black hole about the complaint, about the complaint, about the complaint. So do we keep a check on that or monitor that?
Oh yes, our ombudsman helps us keep a check on that, and I have regular reviews with the ombudsman, and several times throughout the year.
Well, sorry, but below the ombudsman, because the ombudsman is that's getting that's gone into a more formal process. But just within the kind of local complaints procedure, that's what I'm more interested in. I'm not interested in the ombudsman in that respect. But.
Yeah, well, the reason why I mention the ombudsman is because that begins to give us an early indication that actually we've got an issue that we need to go back and look at. In terms of complaints handling, then yes, there is a common theme. Our biggest issue with complaints handling is the timeliness of it, which is why I'm saying that I'm really pleased that we've halved the amount of time that it takes to handle our complaints. But actually, one of the biggest challenges we've got is making sure that we get clinical engagement to enable us to handle those complaints in a timely and effective manner. That said, the work that we're doing directly with our clinical leads and with our triumvirate teams around the complaints toolkit is absolutely beginning to have some traction. There are one or two areas we've still got to do more work on, so we do monitor that, and the team know that if we are having complaints about the way their complaints have been handling, that leads to a further conversation about how do we put that right.
Yeah, thank you.
Okay, James.
Thank you, Chair. So I think this is it's a fab report, and it gives us an opportunity for oversight. I suppose something that I was reflecting on reading the papers was we've got a highlight on our medical workforce, our nursing workforce, actually, and our administration colleagues. But actually, how do we identify opportunities of what we're doing brilliantly well and what we want to celebrate, but also opportunities to learn and from other professions, Mandy? And I wasn't sure if we were restricted through FFT based on the template or whether it's something we could do.
We can do bespoke. So what we do is, so for example, the sexual health team asks for a very bespoke survey response, so we can do that. We are limited in so much that we only get to know what the patients tell us. So, and we have had some really good feedback about therapists, and in fact, I brought stories here about therapy and the difference it's made to patients' experience. So we do try to make sure that we cover across the broad range. It's not just focused on a specific group, but usually the patient will call something out, which is where we're getting that. If we've got themes, so bearing in mind that each of our directorates now have access to the complaints dashboard, they're able to go in, and through the Civica system, they can go in, they can review the feedback that they've had, they can print off reports from that. They do you said, we did, it's up on the boards, it's there and visible for people. So we try to make sure it's across, not just focused on one.
Okay, thank you. So, Mandy, the last time you presented it, thank you very much. You love it, really. So we are asked to receive the report, which we have done, and again, thank you very much. So final item, and then we'll take a break, which is the nurse staffing.
So I've given the opportunity to Sharon.
Sharon.
That's what I did, to present this particular report.
Which we've all read.
Which you've all read. Yes.
Thank you. So I do appreciate that the board is well cited on the methodology that we use to calculate the nurse staffing levels and the reporting arrangements that we have in place as well. Just to provide additional assurance, our nurse staffing programme lead networks of peers across Wales, and is a member of the Always Nurse Staffing Group as well, which is a group that I now chair as well. So in terms of the purpose of that group is to ensure that NHS Wales not only meets the statutory responsibilities of the Act, but through a Once for Wales lens. So through that approach, it not only gives us the opportunity to participate in any benchmarking exercise, but also to influence that as well going forward. So I just put out a couple of highlights from the report. And for this cycle, as you can see in the report, table 1, we look at Bronglais, Prince Philip and Glangwynedd Hospital, and there is an uplift requirement of £143,670. And the main driver for that increase is the acuity and activity on the ENT ward in Glangwynedd Hospital, and it's based on the complexity of cases that are coming through the system, which has been sustained across the year. You note that the Willie Bush position is not included in the table, but there is a narrative in section 1, page 2 of the report, and that's due to a reduction in medical bed capacity due to the ongoing RAC work in Willie Bush. So again, to provide assurance, the board is asked to note the rosters on the required establishments, wards, and the current functions have been discussed with designated person to my left, and they are included as appendix 1 in the report for your information. So this has concluded that the assessment against the spring cycle suggests the requirement for Willie Bush is a reduction of £451,310. The outcome of the autumn cycle, however, should be viewed with some caution in terms of how we can sustain, as Andrew said, revised models of care and realise the benefits, as opposed to returning in its entirety to previous models of care, but just to add a little bit of caution in relation to that really. I haven't got anything additional. I'm just happy to take any questions.
Thank you very much. Thank you. You've answered all I had about comparison, so thank you. Any questions on this report? No? Okay. Right. Is that you? No, sorry. Oh, yeah, right. Oh, okay, sorry. Okay, so if well done, thank you, Sharon. So we're asked to take assurance of the 3 bullet points there, which are on page 3 of the S-form. Are we content with that? Yes. Thank you very much. So I am intending to catch us up. So just for those of you still to present papers, to do so succinctly as we move on. We are going to take a half-hour break for lunch, so we'll be back at 1:45. Karen will bring us on. Okay, thank you. Right, welcome back from our lunch break. So we'll move on with the rest of the agenda, which we still have quite a bit to get through. So the first section in the delivering the plan is the integrated performance assurance report. Hugh.
Chair, I'm very conscious of the time today, so I won't go into the report in any detail. The report's pretty standard in its nature now, and go through the achievements, the initiatives, the issues and challenges we're facing in our performance space. And I'm sure Andrew will come in and Jill with some of the operational context. So I'll go straight to open it up to questions so that we get into some of the issues or concerns of the board.
Right, thank you very much. So questions for you or others on this report?
Thank you, Chair. On page 4, we have key initiatives and improvements impacting our performance. A couple of things on there. In terms of uptake on the extra capacity reports on the diagnostic assessments for ASD, are we confident that we're going to use all that capacity this year? Just conscious that there's only 212 refurbished units to date, and we're the end of the year. So that's the first one.
Shall we answer that straight away, or do you want to ask them more? That's up to you.
Yeah, well,
because that's an easy one for me to start with. That's why. In so much as that we are on track with the level of referrals into that service to maximise the use of that capacity for them.
Next one is actually the next stepping stone is using T-Brain. Just wondering whether we identify the capital for the refurbishment that's going to be required in that to use it.
Okay, so in terms of those, there's the service we're working with the estates team. They're working through the costs of the work that are required. We do have a funding source from Welsh Government that would cover the costs of that scheme, which we put the costs out with. They're still working through the detail.
So you that was the issue on the package. Next one, witness validation. What the significant numbers have been removed from the waiting lists. Just wondering about the reasons that they've chosen to be removed from the waiting list, whether or not our population have funds themselves to go elsewhere for the private treatment, or whether it's general improvement in condition no longer covers treatment.
That's a good question. So in terms of the detail, I probably want to come back with a more investigation and I need to come back with a more detailed answer for you now. But obviously all those people that we are contacting and are being validated off are people that are still currently on the waiting list. So for us, they're not known to have treatment. They're still waiting for treatment with us as far as we understand. And there'll be, as you alluded to, there'll be multiple reasons why they may not want to proceed. The treatment may be that they no longer require it, or as you say, they may might find other solutions for that because they were waiting for. But if I could go away and have a bit of detail,
The final is probably the next page, 100-day other organizations provide health framework rates for therapy services and agency staff. I just wonder whether we've estimated that the Welsh Government could try and get a level playing field across Wales, and whether we would do anything on that if we could.
it's not something that I've escalated through an operational route so far. We're aware that across a range of workforce professions, we often find ourselves in a position whereby different health boards will pay different rates that are over and above whatever the agreed framework for payment. It creates a bit of a challenge for all organisations when that word gets out and people ask for those rates locally. I'm not sure whether it's something workforce directors have picked up or whether I'm not fairly frustrated with this. It's not something I'm with, it's not something I'm with, but whether it's come through the workforce discussions, I'm not sure the focus is on that.
I think in terms of this one, there is a big as well that needs an out of agency for those groups, and part of that will be whether it's service areas where we're using more agents or higher costs so that they can look at more lifetime to help how we reduce costs and but also into the culture. So
I do, yeah, thank you, Jeff. So I think getting to the root as to the reason to use agency is really important for us as a health board and much wider. But for our focus right now, I think it really needs to be around understanding what the capacity is for us to get the service that we need. So there was a paper that was scheduled to go to QSEC in December around some of the challenges around waiting lists and potential harm patients, potential harm. But what I've asked for through Mandy is exactly now have a conversation with Anna is to defer that paper. And the reason for that is what we need is to ask the correct question of the service lead and the clinical director, which is what do we need to deliver safe and effective services and have equity of access to that service based on the skill mix that we know we can achieve right now in the short and medium term, whilst also thinking about our long-term workforce plans. So I think it's a very important thing to bring up, but it doesn't negate the need to go into that deep dive, which I hope to bring back to boards and updates in QSEC next meeting.
Yeah, just on the table, you know, the key areas for performance improvement page 3 there. I'm just being incredibly, you know, there are a few, the trajectory kind of columns, not applicable. I'm just thinking, why are they like that? Because I'm sure we've been tracking ambulance handovers over 4 hours, you know, in the past 3. There's a couple there with no, you can't see the performance against them. So I'm just wondering, why are they not color-coded?
It's probably one for me to take away look at, because we definitely, as you say, we do have trajectories, and I thought they were in the main body of the report as well around 4-hour ambulance handover delays, because we'd set an improvement trajectory against those figures and had to submit that nationally. So we probably need to just go and double check why that's not featured.
Yeah.
It certainly features in our executive team aspect, so we should have that.
Yeah, I think on delayed pathways of care, Welsh Government have changed the criteria and they stood down the counting of that for a period of time, particularly following COVID, and now we've got a new metric, so you're not really able to possibly track the variation against this, but I'm sure that variation will be able to be demonstrated going forward. But we've got a new metric now, so it was delayed transfers of care, it's now delayed pathways of care. And we are submitting the data to Welsh Government on in a required basis.
So we should be able to track that in this report. Okay, thank you.
My question is about patient flow and whether or not we want to answer it now or in the next item. And whether or not this is up to date. You're saying that there's 192 of inpatients ready to leave. What is being done regionally and strategically with our 3 local authority partners about this number? Because as we know, patients deteriorate whilst they're inpatients. So I just want to know and understand the background of the figures.
So do you want to start? And then
Yes. Where we do it, Aaron?
So I think probably the first thing we need to recognise is that it's 192 now. We were at 300 plus sort of for this term of the year. So there has been an improvement. And even through the summer, we were sort of somewhere between 200 and 300 for most of the summer. So there's been an improvement. I think it's also fair to say that the November data is showing a bit of a bounce up again in terms of some of those delays. Obviously, a lot of the actions around this, there's kind of a two-pronged approach to this really for us. One is, as I mentioned earlier on, we know that if we can, there's a window of opportunity in terms of turning people around in 72 hours once they've been admitted. If we can do that, then we tend to find a need on discharge is much less, and the discharge process is much easier to therefore manage, because we're not looking for additional packages of care or placements when they're discharged. So that's one thing, and the number of patients that are showing a length of stay over 21 days is reducing, which suggests to us that some of that work is starting to have an impact. It distorts the length of stay data because the length of stay data is calculated so when people are discharged and the length of time they're waiting to discharge. So then in terms of that, the second end of the pathway then, or the second part of the pathway is on how we speed up the discharge process, and really a key focus over the last few months has been the implementation of the trusted assessor guidance, for which we've got a agreed consistent framework across the health board, although how that translates into local models for delivery may look slightly different between the different counties. They've agreed, though, through our integrated health first group, which has members of the health board and the authority on a consistent framework of how we would approach that and what we would expect to see in that space.
Actually, that's fine. Just coming on that one, when you say 3 local authorities, we have got another 2 local authority areas, i.e. Powys and Betsy. So, or Gwynedd, shall we say. So is that being replicated for patients waiting in Goldhouse?
So we will be having those conversations, I think, my reflection would be our regional partnership work is very focused on the 3 local authorities that are co-terms with the health board footprint. There's a closer relationship with Powys. I wouldn't be confident in Betsy. I don't know if you know, or North Wales, I wouldn't be able to say that.
I would agree with you.
Jill, do you want to add?
I did just wanted to add really, and I think sometimes when you look at the figures and the actions, yes, we can see some demonstration of benefit. We always hope there's nothing gratuitous in there, that i.e. more patients died during that period and therefore that caused the reduction in individuals waiting to leave. There are still issues around our capacity assessments, and also local authorities will challenge us, because whilst we do have still some challenge around social worker assessments, there are still issues for us around our own internal improvement in terms of nursing and therapy assessments that we need to address as well. We've also been trying to work with our care homes as well in terms of improving that capacity, because when we do look at the figures, you will always find that there are possibly about 40 empty beds that could be available. But care homes are individual and independent businesses, and they do have the right to say no. So we did hold a workshop with care homes probably about a month ago now, for 100 attendees. And we wanted to make sure that it was very developmental in terms of understanding their issues and understanding ours. But it was very pleasing to note that we had colleagues from secondary care there as well. And there's a misunderstanding probably in terms of individuals' experience. And Andrew knows that in another workshop, when everyone was going to challenge care homes, I said, a lot of the people who are challenging care homes have never set foot in a care home. They don't understand the difficulty of discharging somebody at 8 o'clock at night when you've got 1 nurse on and 40 residents to care for, and the challenges that gives, and often the care record doesn't come back out with them. So there's a lot that we need to do, and what I've been asking care homes to do is try to respond to us in terms of supporting that process, but we will also support them in terms of trying to address their needs. So that's a big issue for us. I think the issue around trusted assessor, and you will see those different models, is that it's not the panacea. Because although the minister's very interested, and when she came out to a visit recently, she was very interested to understand the progress we were making. But when you look at the reports and the ability to do that, to use a trusted assessor approach, it will be for those low-level assessments, a possible tweak to a package. No local authority is going to agree a commitment of a significant amount of resource that's done by another employee from another organisation. So it's trying to move on where we can, those assessments by training individuals in terms of that. So you're already familiar with the work we've done previously on domiciliary care. So I think it is really trying to make sure that we've got a lot of those opportunities in place. We're continuing to escalate it through our integrated exec group, but it will be about that capacity, being able to open that up and work with our local authority colleagues to move this forward. So a lot of things that we still continue to do, Della.
Okay, thank you. One question, Chantal. I was just curious around, when we're talking about delayed discharges of care, discharges, and in particular for those patients who've been with us for a long time. I know on my walkouts I've met patients who've been with us for maybe 8 months, 2 years plus, but there was no
end in sight in terms of when they were likely to be discharged or sent home, or wherever they might be sent from us?
If I can come back again, because I should have probably included that, Chantal, we do have some individuals, and possibly they are the cohort, because even if you look at the individuals who moved to South Thames, so we walked around those beds during the ministerial visit, we're really sometimes pushing the problem on a little bit. But there will be individuals with quite complex needs, and they will be individuals who are possibly with us for a very long time. We continue to assess those. I asked the team about looking at the threshold of needs so that we can have conversations with, if it is a care home, around that capacity and support that they can provide. But sometimes it is absolutely very difficult to get a package together that is safe. Now, I'm working on a package at the moment we have very few 24-hour packages of care, but where individuals are ventilated, they may have very complex needs. There are issues that only registered nurses can support. It can be extremely difficult to get the right level of support to enable somebody to be cared for safely at home, and to agree the medical cover and the contingency when that possibly breaks down. Is that admission to hospital, blue light, etc. So I think sometimes we don't necessarily understand the level of complexity that some individuals do have. And we did have, for a period of time, probably 25 individuals in Prince Philip who were in that situation with very complex needs that we also couldn't get care home providers to support either, so agencies, and to take that on. So it's something we continue to look at, and also continue to think about options for the future. It won't address it now in terms of NHS-run nursing homes. Local authority will build. We'll look at providing the staff, increasing the amount of agencies that we've got. And as I've said previously, we've seen a number of agencies go out of business in the area as well. So it's something that we continue to review. It's not the best place for individuals to be within our hospital, but the difficulty of getting a safe and sustainable package of care, either in a care home or their own home, can sometimes unfortunately be very, very challenging.
I'm going to leave us on.
Sorry.
No, it's okay, Joe, but I just wonder whether, is this detail going to come out through the primary community care strategy? If not, is this something you could take as a more detailed explanation or update through to SDOC, just to address this issue? Because as Andrew said, the figures have been going down, but there is a bit of a blip, and we're coming into the winter and, we've had restrictions. So if I can just take it out of here for today, but we do make sure that there's a more detailed explanation. Okay, thank you very much. So, paper us to take assurance. I think probably we should be noting this paper because there's information. It's good and some over there. So happy to do that, to note the paper. So I'll move us on now to the operational update. Andrew, you're going to start. We've obviously read already. So can you anything to highlight, and then we can have any questions?
Yeah, there were a couple of things I did want to pull out if I may, Chair.
Yeah,
and there were a couple of things probably just partially linking back into the performance conversation. I just wanted to flag as well that with the paper, just so that they're recorded formally, given that we're in enhanced monitoring for some of those areas. I just wanted to make sure we covered them properly, and I didn't want to confuse the other conversation. So just in terms of some of the 3 or 4 and some of the performance, I can take this part of the update. So a couple of the things that I just wanted to flag that I know have been on our radar and agenda as a board over the last few months. The first one is the situation of RAP, and reinforced autoclave aerated concrete in Withybush. And that was just to highlight that we've now repaired and reinstated 2 of the wards in Withybush. The replacement kitchen facility should be operational by the end of next week, certainly the week after, which will mean we'll have a fully functioning canteen for staff and visitors on site again, whilst the repair works are then continued on the kitchens, which I'm due to finish till next summer. And the third ward will be ready for operational use on the 8th of January. So that will mean we've got 3 of the ward areas back online. Although the work we complete by Christmas, we're holding out operation to use that in the new year. We just think it'll be the best time to bring it back on. The other 2 wards then don't complete till the end of March. In February, the outpatient work starts, that will be fixed in the summer. So it's just a bit of an update there. I think we'll get to a point in December where we will probably be in a place whereby we can consider de-escalation from internal major incident status. I think that two things that we were mindful of were, one, we may still need some mutual aid support whilst we work through the process of discharging patients from South Pembrokeshire Hospital to enable the third ward to reopen in the new year. And we felt that whilst we still didn't really have a fully functioning catering service on site, that was affecting our staff and public, that was another factor that felt a bit different in terms of the support we were needing to enlist to provide that service. So we do review it at our Silver group, but it's just the fact I think we'll get close to that in the next month. The second issue that we've talked about here before, we received a paper early on in the year, in May, was around the emergency general surgery rota in Withybush, and we made a temporary change to that, as you know, which saw patients that required emergency surgery transferred to Glencree. We reinstated the model in Withybush at the start of November. That was in part due to the appointment of a locum consultant to the site, and also in part due to some concerns starting to be raised by some of the surgeons that were supporting that model and their views as to how sustainable that was for a further period. So we were able to appoint a locum. They're in place, so we've been able to manage the emergency general surgery rotation, which as it was prior to the temporary change. The temporary change has ceased. We were optimistic that we had appointed an NHS locum in the last couple of weeks. However, we received notification yesterday that for personal reasons and family reasons, they were now no longer able to take up the offer. So we're having to go back around the loop to see whether any of the other candidates that we interviewed as part of that process would be suitable or still interested. So some good news. So some good news generally, but I was hoping I was going to be so well at the start of the week. I thought I was saying we'd appointed an NHS locum as well, but unfortunately, they had to be. I also wanted to flag just the focus on regional working and the fact that the Welsh Government and Minister are putting a lot of emphasis on the need for us to work regionally. This is for the South East, South West Wales and North Wales, but for us to work regionally with our neighbouring health boards to work through, in particular, how we can improve access and reduce waiting times and long waits for orthopaedics and ophthalmology. We actually had our first regional clinical workshop in the Southwest for orthopaedics yesterday. We've started to mobilise a programme group and a small team, and Welsh Government have allocated some support to us in the short term in the form of Karina Casey, who works in the National and the NHS Executive, to come and provide some programme support to us for that over the next few months. And we have, Swansea have advertised on the programme's behalf programme manager post to support that programme across the two organisations. So we'll start to mobilise a bit of a core team soon to work with me as the SRO and Mark Mullins, who's the clinical lead at an orthopaedic surgeon based in Swansea, to start taking that conversation forward. At the moment, we're very much focusing on how we maximise the use of capacity across the two organisations to reduce the burden on waiters. But that will become something I think we'll come back to over the course of the next few months. I'm also conscious we've got the winter plan in there, so I've definitely started lands there for information. I need to stress it's going to. I think we're facing a very challenging winter. As we touched on earlier on, the financial forecast doesn't afford me any opportunity to surge capacity like we might normally do so from the winter. So that immediately puts a challenge into the system in terms of some of the decisions around escalation we might ordinarily make with that financial challenge and context. So that's just something I need to flag. But we're doing, at the moment, if you look at our urgent emergency care performance, we're doing better this year than we were 12 months ago. Even in October, which was a worse month than we've seen for a couple of months, with 60 less beds in the system. So there is real reason to believe that and from the data as well, that our transforming urgent emergency care programme, the actions we're taking around conveyance, conversion and complexity are contributing to that ability to improve performance. relevant and still live within a reduced level of capacity. The only other two things I then really wanted to flag, Chair, and apologies, was in terms of planned care, the three kind of milestones the Welsh Government are holding or monitoring this against at the moment are: there was a milestone for 97% of people to be treated within 2 years by the end of December. I'm pleased to say we're on track to deliver that by the end of December, and we're very confident in that. The other two are both for the end of March, which is to have 0 patients waiting over 156 weeks, just 3 years, and for 99% of people to be treated in 104 weeks, so within 2 years. Those are looking more challenging for us at the moment. Our forecast would see us have between 400 and 500 patients waiting over 3 years, all in orthopaedics. So every other specialty would be cleared in terms of their long waiters. Orthopaedics, where we still have a challenge. And we're at the moment, our forecast would see us have around 2,500 patients waiting over 2 years at the end of March. For us to get to 99%, we need that figure to be about 800 to 900. We're reviewing our position because we think we can get a lot closer to that than we're currently forecasting. But some of the opportunities may just depend in terms of how our spend on the 2.8 million that we've allocated in the financial plan goes, and whether there's any slippage that affords us the opportunity to increase some activity within the cohort as well. The final thing, and I'll say before I pause, Chair, was I'm conscious cancer has also been a big focus for us as a board, and our concern around the headline performance figure. And I have to recognise that the headline performance still remains too low at 46%. And it will feel as though our backlog reduction is a bit stubborn, still at 370 patients in that backlog number. I'm confident that in November we will see that reduce to between 300 and 350 patients in the backlog, and we're cautiously optimistic. I think the NHS executive and their team of analysis are more optimistic than we are allowing ourselves to be at the moment, because we know how fragile some of this can be in terms of workforce and what can flip it in the wrong direction for us. But they're cautiously optimistic that by the end of Q4 we'll be consistently performing at 60% plus. We know to get to 75%, which is the target, the single cancer pathway, we need to have a backlog between 150 to 200. So obviously we're going to continue to work on that, but we do believe that we will see an improvement in the headline performance figure as we get towards February and March, which will be a real positive step, because the changes we've made in the cancer pathway to facilitate that are sustainable changes. They haven't been one-off hits to reduce numbers waiting at different points, and that's why the national team are very optimistic about where we are, because they can see that starting to play through in the data now. So the percentage of people being identified as having cancer and not within the first 28 days is increasing every month at the moment, which is a good metric to say that we'll start to see that benefit before. I'll pause there.
I was going to say, can I just ask a question about planned care? How much do you know yet about the review, the GIRF review on theatre utilisation? Is that sort of feed through yet, or is it too soon?
So the process has started, and there are touch points. There's a national board, and the fortnightly touch point meetings have begun. We've only just in the last couple of weeks received the data back, and I think it's fair to say there's still significant concerns being expressed, not just by us as a service and our informatics team, but by other health boards, services and informatics team, about the comparability of some of the data across organisations, because some of the data they've requested is counted and measured in different ways between health boards. So we have through the programme expressed concern that if that's going to be used comparably, we need to be very cautious around how heavy that comparison is being drawn to pit organisations against each other, because it could become very easy to improve your utilisation by changing your definitions without actually delivering any productivity benefit. And I'm very keen that through that work we actually deliver an increased level of capacity. Otherwise we miss the point of the work.
Yeah, absolutely. Okay, so quite a lot there. There's quite lots of the information in the paper, so I don't know if there are any questions on any of this. And No, sorry.
Just one very quick one. You haven't touched on the cost management of the medical practice.
Sorry, I was going to bring this in.
Okay, quickly.
So notice, two questions. One, I know the process is in the training on that, but more of the plans for cross hands and the capital scheme there, with what that is going to impact on the plans for that.
I mean, obviously we can't prejudge the outcome, but certainly for if it were to go out to tender for an alternative general medical practice or an alternative provider of medical services, we would be wanting to invite interest on the basis of actually that new building. Similarly, if it became a managed practice, we would be committing as a health board that we would be wanting to look at that as an opportunity, because we would still also need premises in terms of delivering that. The only option where that might not be possible is if the list was dispersed.
Steve, you want to come in and just something on to that as
Just
well?
a minor point in relation to the interrogation incident study in relation to that. Is that we'll need to call a board meeting to sign that off, and then we'll bring it up to the board in January for that.
The other thing I just wanted to add, and it's not actually in the paper, but the IMs did receive a briefing on where we were with our vaccination rates, both COVID, flu, for residents and also staff. So we've had that information. It's not sort of public, and there's a big campaign going on to increase uptake. So if we can include that in the operational update or in a separate report, Aldiana, to the January board, then hopefully we'll have seen some improvement in the information. But I just wanted to say, and if any of the IMs weren't able to make the meeting, the information was recorded. So I'd rather than sort of go into much detail today.
Yeah,
Yeah, and we've shared the chief exec's briefing with the IMs. Okay, so thank you. Okay, sorry.
Just need to with clinical services now.
Yes, right. Lee, sorry, I thought you were telling me something. I've missed someone. Yes, just moving on. Yeah, okay, I'm here. Clinical services, Lee.
Thank you. So it's a fairly simple update report at this point.
Sorry, Lee. Just kidding. Yeah, carry on.
Okay, so I was just saying that we did a staff survey and the targeted early engagement survey of patient users has closed as well. We had over 6,000 responses across all the services, which is excellent and good coverage across each of them. So the key point, I think, just for board members to be aware of is the amendment we're proposing for the timeline. We did flag in the last board meeting that there was a risk of that, and that is and there has now been some slippage on the dates. So that would mean we'll bring the issue paper to the March board. The upside of that is that it does allow us to have a more thorough discussion with the board seminar in February, which we hadn't previously put into the timetable. And I think that's actually, in hindsight, going to be very important, because there's a good number of services there. There's a lot of detail. It's going to take quite a bit of time for the board to get up there, to get our heads around all the information. So I think that'll help ahead of the March board discussion. I would not help with questions.
Any questions? The reports, are we okay with that one? Okay, thank you very much. So recommendations on page 6 are there, and we look forward to the seminar discussions in February. Thank you very much. So we will now move on to the board assurance framework. Joe?
Yeah, so as a reminder for board members, the BAC provides the board with visual representation against progress against HR's strategic objectives. And since the BAC was presented in July 2023, it has been through all the committees and we've received a progress report about where we are with delivery of the planning objectives that relate to each of the strategic objectives. So as we indicated earlier in the annual plan that came to the board, the implications now of workforce slow will be linked back to the BAC. So the outcome measures have also been reviewed and principal risk by the executive team yesterday and a couple of weeks ago. And the dashboard will show you where we are. We're on track with everything with the exception of 3A, which is to curve, and the estate strategy 5A and DCAB. But just to apologise to members, when the paper was shared, it was some of the links were not working, so it was showing things were on track when they weren't. So we fixed those now, so the version that's available to the public is the correct version, Chair.
Great, thank you very much, Jo. Any questions on the assurance framework? No? Okay, so we're asked to seek assurance on, we've had that information. You're okay with that? Thank you. So we've had lunch, so I can move on. Right, we're now to the business case section, and I'm just going to get my tongue right around this. It's the digitally enabled transformation plan. Hugh. Brief summary.
I'll give a summary of the work that's been done and welcome a discussion on the issues arising. So this paper has been a long time in the gestation and follows a period of engagement across the Health Board and with partners in local authorities, third sector, DHCW and Welsh Government, and I'm grateful to everyone for their support in getting us to this point. We all know the challenges that we're facing: a growing elderly population, some limited areas where staffing is fragile, friction in communication between patients and their families and the Health Board, and services that are inherently dispersed across sites, across numerous organisations, and friction in the communication between each of those elements. If we're truly to become productive at a system level and release our colleagues' time to be able to do what they need to do, then digital transformation is needed at scale. The document that we have here outlines the strategic and management case for change, and once we've agreed these, we will be working with procurement and with commercial organisations to look at the economic, financial and commercial cases. There is a lot of interest from the market. We put a prior information notice out to the market to say that we may be coming out to talk about digital transformation, and we've had in excess of 40 organisations expressing an interest in working with us. So quite a lot of interest in this work. It builds on the work we've done over the last few years when we've seen a time of unprecedented change and level of digital adoption. It also builds on the work we've done to ensure our cyber resilience, which continues. The improvements we've made to our infrastructure across our sites, still more work to do. Our work on the resilience of our teams within and our system development within the digital team, and our digital readiness through the HIMSS assessment process. That's a process that's been undertaken nationally across Wales. And the dedicated resource we've got to support digital inclusion and benefit realisation within the team. And of course, the relationships we've been building with Welsh Government, DHCW and our regional partners in the digital space. We've been on quite an involved journey as part of this work, and we've tested the imperatives that are important to colleagues across the system, the barriers to transformation, what we need to do to consolidate systems we have across the organisation. We have a huge number of digital systems, and there is a degree of consolidation that would be necessary as part of this, and the sheer complexity of our infrastructure, which needs to be simplified. I'm pleased with the work that we've done to develop personas. This builds on Taylor Jones and the work that was done as part of the Health in Mid and West Wales, and helps us simulate the needs of the users we have to our services, which includes patients, their families, and our different staff groups and their settings. And using those personas allows us to think about the patient pathway and to think about ensuring then that people are at the heart impact of any change that we make. There are 4 key pillars that we are talking about as part of this transformation programme. The first is we need to maximise the use of the patient app. The NHS Wales app is in development and is being tested, and we are a pathfinder in that. We need to put as much as we can in the control and hands of patients and their families to reduce that friction in communication from patient and person with a health and care service. And we've already started that. Hybrid printer post service is now operational. And letters are being distributed to that. The next phase is to switch on the digital element of that, which will allow us to distribute those by text message. We don't have an electronic patient record in Wales. Building a customer relationship management system would be a way of adding a layer in, which would pull relevant information from core systems and allow us to have one view of patients across the system that is relevant to the staff, to the member of staff looking at that patient at any point in time, and that will reduce friction between across the health and care sector. And we heard earlier about the challenge, Jill, in discharging to care homes when the care record doesn't go with the patient. This would allow us to overcome that kind of issue. We want to develop the regional data fabric, which will allow us to then share data, pull all that together into one repository and make sure then that everything else can overlay on that and have one view of the patient, which will allow us to better predict the services that are needed at any point in time to patients and in a short and medium time frame. And lastly, we need to develop the remote monitoring to allow to allow better coordination of services between health and care, building on the good work that's been done already in pockets across the health board and with our local authorities. We've developed programme charters for each of those, which kind of show the high-level commitments, and we'll be building on those as we pull the more detailed full business cases together. This document is just the beginning. We need to explore in detail the individual business cases, and we'll bring those back to board for approval. I'm confident that the investment will give us productivity benefits. What I'm not confident about at this stage is that it will give us the scale of cashable benefits that we know we need to see given the financial challenge we have as a health board. Recognising that, I'm working with Welsh Government and DHCW to understand how we might fund individual business cases, either in collaboration with partners, with Welsh Government, with DHCW, where we can then secure that resource and make sure that the risk doesn't entirely sit within our health boards, working quite closely with those partners. And there's real interest in that approach, but there's no commitment at this stage, and I just want to be open about that. I want to give assurance to the board that we won't enter into any commitment to incur any additional costs without board agreement. We will bring individual cases back to board. And as part of that, as part of this work, I think one thing I've recognised is that we have limitations within our team. With each programme of work that we do, we've got to staff up on a fixed term and on an agency basis, and that's not a particularly robust or reliable way for which to work. And I don't want us to work on that basis going forward. We need to create something that's much more stable for us. That's how we rolled out the nursing care record. It was by bringing external agency staff in. It's ineffective, it's time consuming, and it's risky. And it's a very challenging way to deliver change. And what we need is a partner that is reliable, that we can work with, where we can source the skills that we need, which can be very bespoke depending on the individual project we are working on, especially some of the technical skills that we need. I'm asking the board for approval to go to market for a competitive tendering process to allow us to undertake a call-off contract effectively, to buy that resource in as and when funding becomes available. But I do stress this is as and when funding becomes available, and it will be as and when individual business cases are followed and board has approved those cases. I'm conscious the process of going out to market can take up to 6 months, so I do want to get going with that to avoid any further future delay. Just for some assurance as well, before I open up to questions, we revised our governance arrangements in digital. We now have a digital oversight group, which will scrutinise and provide assurance to the Sustainable Resources Committee, which then itself will scrutinise before recommending approval of any individual business case to board. So we've got that robust package of governance to wrap around it. points. Chair, I'm conscious there's a lot in there. Try to be as brief as I can in the introduction, given the complexity of what we're trying to achieve, but welcome any comments.
Answers and right. I suppose issues and concerns in your introduction, but I'll put out for questions now.
Yeah, I've got some practical questions for you. How are our areas notorious for bad connectivity? What is happening regionally to address that?
Yeah, so a number of things, Openreach and a number of the telecoms providers are working with the regional growth. So we've got the Swansea Bay City deal and we've got Mid Wales growth deal. They're working as part of that process to improve connectivity, and there is significant commercial investment going into West Wales to remedy some of the challenges we've got. I'm sure that there will be challenges. Of course, we're in a rural community and those challenges will remain in certain areas. Doesn't mean that we shouldn't be driving change where we can, recognising that there will be challenges in some areas that may require satellite connectivity in the future. For example, we've got some discussion going on with European Space Agency, and they're expressing some interest in wanting to work on how to maintain 4 and 5G connectivity in the most challenged areas.
Well, fly me to the Roger.
Yeah, thank you. And, you know, this is a detailed paper, and if you look at the recommendations, kind of those 3 points and the first point, then we note that benefits realisation methodology is important part in that first one. I was just wondering, should that not be an agree rather than a note? I'm just asking, should it, because it's an important part, isn't it? I'm just thinking, should we agree
yes.
rather than a note? Because note is that was the only thing I picked up, perhaps. And,
It will be incorporated as part, so I'm happy for us to agree that, absolutely.
Can't pick up there, it's just kind of wording.
No, all right. Steve, something.
Yeah, just a couple of things. Well, I mean, I think for me, this has been a long time in gestation, but the proof, I think, in time to be one of the most important things that we do alongside probably some other key parts of work for us. So, thinking about the work that's going on around our roadmap for financial sustainability, there's a number of elements to that, some of which are already very much in train work, the infrastructure program business case and how we organise ourselves. From an infrastructure point of view, we've got the social model for health and wellbeing work, which is looking at the demand side of the equation for us and trying to have some influence on demand. This sits very much in the sort of the productivity, doing as much as we can with what we've got in the best way possible to support the quality, safety and access for our local population. So it feels quite important from that point of view. I think the thing that we're doing, which perhaps I know hasn't yet been done in Wales, is to try and set out, I think the first thing I've seen in my career is not so much a set of solutions or a bunch of widgets that might fix bits of the system, because my experience of digital tasks has been we get really convincing business cases for things. We don't know the questions to ask about how those things fit into what we're trying to achieve more strategically. It can be a bit like the tail wagging the dog. This is, not to push that image too far, this is the dog. And so this tells us actually what it is that we want to achieve, that digital can help us to achieve. And then all of those things that might follow, those business cases that might follow, which will have to stand off for on their own merits, whether that's in cashable benefit, productivity benefit, but with a funding stream identified against that to support that in the short term at least. It will allow the board to make judgments about where to go next and how to make all of this start to work together. So some of the very complex architectural drawings here, I think, are our plumbing diagram for going forward, which I don't think we've ever had before. And that leads to my final point, really, which is probably just to acknowledge that Digital Health and Care Wales, Welsh Government are looking at this. It doesn't feel like this exists at the moment, but in some ways we're doing a bit of a test for them in this. But I would hope in time that this becomes an all Wales approach, so that we can merge it together. But we very much offered, Hugh's offered, to ensure that we do it very much as a goldfish bowl, that people can learn from us, that will help us to come and see what we're doing, so that we can get the benefit maximised across the whole place. I think it's a really important step forward.
Are there any specific questions, Winston?
Yeah, yeah, I was quite struck by under the strategic case that there is no single shared patient record, because there is that in England, but there isn't that in Wales. Do you think is it possible for us to go ahead with that in the absence of Welsh Government, or is Welsh Government working on creating a single shared patient record? Because I can see the benefits for creating one, because then you can share that across systems, and individuals can own their own shared patient record and also validate what's in it. So, any thoughts on that, or is that part of the wider discussion in these areas?
Yeah, thank you. There is a demographic record that takes data and makes sure that the demographic data that we have is consistent with others across the system, but no shared patient record in itself. And essentially, a customer relationship management system is something that will then sit above it and pull up relevant bits of information from various records that we have across the system, be that in secondary care, be that primary care, be that social care, and then you can at least see some of the basic information that would be included. So it's in effect a proxy for a single patient record, but not quite one. Implementing that, there are organisations that are implementing a single electronic patient record. They are notoriously expensive, complex, generally secondary care focused actually, and still not much community focused. So this would be a second best solution for us, but one that I think is much more affordable.
Do you think Welsh Government's working on this themselves, just to try and create something that people share across health boards?
There is interest in the work that we're doing here and working with us on enabling this for us as a test case, I guess, for the applicability of that more broadly.
Thank you.
I'll just ask, it might be a dull question, but essentially we got the list of things like workforce risk, legal, etc. You've got quality at the bottom. It says not applicable. Is that right? I wonder, because digital access is very much an age issue, disability issue, etc. So I wonder, am I missing something here?
I think that's a valid challenge actually, and given the work that we're doing on digital inclusion is one that I know we've got a response to. So I'll pick that up as part of pulling together the detailed cases that follow.
And that would flow into socio-economic duty as well, for people who are, socially challenged, economically challenged. Yeah.
Thanks. Thank you. Yeah. I just noticed that the chief executive's allergies are changing. We've had dogs, plumbing, and goldfish today. Okay, so yeah. No, it's okay. So, no more questions. Thank you, Hugh. I think we've obviously watched this space. And if I take some recommendations on page 6, we'll change the first one, which is to agree those bullet points. And the others, as they're listed, are we content to approve those? Thank you. And you, Hugh, to you again.
Thank you, Chair. And yes, this is the outline business case for an electronic prescribing medicines administration system, EPMA. It's important to note, Chair, that this is just for the secondary care element of an EPMA. It doesn't include the other elements, primary care, patient access, shared medicines record. They're all being progressed by DHCW on behalf of NHS Wales, and indeed is already operational in parts now. The business case here is based on national work that's being done across Wales, and we're learning the lessons from implementation elsewhere. The costs for this are significant, and I do want to come back to the impact of that. So it's 10.6 million over 7 years, and we're likely to need to fund 5.5 million of that over 7 years ourselves. We don't know the costs for sure without engaging with the market. So the request for the board today is to allow us to engage with the market. There are 2 providers on the framework that's been already procured across Wales, but we have to individually procure from that framework. So 3 on the framework, not 2. And we will be engaging with the market to undertake that test, and then we'll bring back a full business case accordingly. We've got the full costs and benefits included. Rollout for this is going to be quite lengthy. It's quite a complex system. would take about 2 years for us to roll out. But we do know that this will have the ability to enhance patient safety and minimise errors, improve outcomes by embedding evidence-based medicine, and improve connectivity across the system by streamlining medication workflows. And again, approving this will allow us to move to the next stage, and we won't make any financial commitment until the full business case has come back to board.
Thank you, Hugh. Any questions? No? Nice, good to see. I'd be just thinking, Jill, could be useful at some point to bring you through to perhaps SDOC where you are with where we are with the primary care prescribing, and perhaps the NHS app as well. Link the two together, because I know primary care have been crying out for this. So it's good to see the publicity that it's started. Okay.
I suppose it's just interesting, if I may, Chair, to note that in North Wales, the start of it is actually bringing primary care. It's on the news recently. So my personal view is that if we don't progress around DPMA, the benefits both from an efficiency, effectiveness and cost effectiveness perspective and patient safety won't be realised. So it's one of the areas that I think is a very urgent priority for us.
Thank you. The GPs have been crying out for this sometimes.
So, but I've not been on that benefits realisation, so when the full business case does come, I need to understand what the benefits are, how they're going to be realised, and the timing of those benefits as well.
Absolutely.
Because otherwise we could be potentially signing up for something which is just going to, I can see there are clearly patient benefits, the prescribing benefits, the kind of information that we're going to get ability to share. But we actually need to see that quantified as well, I think.
Yeah. Okay. So the other questions, the recommendations are on page 8. So we content to agree those? Yes, thank you. So we're now moving into the annual report. We've just got the one annual report, which I know has already been discussed and presented to SDOC. Lucy, Aldiana?
Yeah, thank you. So this is the did go to the SDOC.
Can you speak up a bit louder?
Excuse me. I'm recovering, but it's fine. Hopefully you can hear me now. So it's the annual report on the well-being of future generations that did go to the SDOC committee, and it was recommended to come to the board for publication as an annual report. So happy to take any questions.
It's really good report, actually. Any questions for Aldiana?
No, it states the objectives for us that remain the same, and it states the priorities of the 3 PSBs following their early assessments, well-being assessments earlier this year, and we're trying to replace all of them.
Yeah, and that's really good to look to how we bring it all together. Absolutely. Yeah. Thank you very much. So we have the recommendations, page 3. Content with that. Thank you. So we're now on to insurance section. The first one is sustainable resources, Winston.
Yeah, I just want to bring the board's attention to a few things because we've already discussed many of the issues in this report before. So, firstly, I just want to pick on what we approved. You can find the right page. So we approved the financial procedures and update to those special payments procedure. We also approved the changes to the sort of digital oversight. The digital oversight group is now going today, the digital oversight group has been dissolved and is replaced by the agile digital business group. And I think the reason why we've done so is so that we can be a bit more agile and innovative in the way in which we progress with our digital strategy. The things that we have discussed I want to bring to the board's attention are, I think you mentioned this earlier, was that our funding that we received this year is conditional upon delivery. And so that may mean that our longer term financial position gets a lot worse. So it's important that the board recognises that and tries its level best to achieve what we can achieve by the year end, which I think I can see that the board is already doing so in the updates that we received earlier. There was a risk around the winter financial surge. I think Maynard asked the question earlier on this one. There was a risk that we'll have to open up more capacity in order to respond to demand during this month, the next month, and the month after. The other thing I just want to bring the board's attention to is there's a concern around regional funding arrangements regarding the Healthcare Commission and contractors, specifically with Swansea Bay Health Board, and this relates to the waiting list and how that funding has been allocated across Wales. I think our risk here was that if Swansea Bay decides to focus on its own patients, then our patients on our waiting list could get worse because we're waiting to get access into their facilities. And I think that's all I wanted to highlight to the board from SRC.
Thank you. Any questions?
Can I just the change in the net, maybe it doesn't matter, but the digital oversight group versus that agile business. I suppose I don't know the difference between the two, but I am cognizant of the fact we've just agreed quite a big program around digital. So I was just checking that is that the group that's going to oversee that piece of work?
I don't know, we're going to ask you to clarify.
So it's the digital oversight group that's been created. We have set down the agile group. The agile group.
That way around.
I got the wrong way around there.
Yes.
I do apologize.
The agile group was set up at the start of COVID, given the changes that we had to make during COVID with PACE. We've set that down and set up the oversight group. It's got Maynard on the group as the independent member to give us that independent scrutiny as well, which will help guide our thinking in the future.
Thank you.
It does fit with the earlier. Okay, thank you. Thank you very much. So we'll move on to Esther.
Thank you, Chair. Nothing to add. It's not already in the paper.
Okay.
We've already approved the overview budget annual report. Just make the matters of concerns and questions.
Okay, thank you. Any questions? No? Okay, and then we've got the People Committee. Chantal's had to go. Anna, and you're the Vice Chair, yes. Betty. I can't remember.
I am Judith.
Right, anything you want me on the
Anything
you'd like to highlight?
I'm racking my brains. Let me have a look at anything towards the end. Maybe Lisa can help me out if there's
not,
anything clear. So nothing needs to be escalated. So I would be very happy to take any questions, and my memory would serve me right.
That's fine. Well handled. Any questions for Anna? No?
Thank you.
Please, thank you. Sorry about that. I made an assumption. Okay, so next one is the Health and Safety Committee. Anne, anything you want to highlight?
Thank you. There's nothing to escalate at board level, but there's a couple of things I'd like to identify. The new CCTV cameras replacing the old ones have been completed in 2 of the hospitals, and the whole thing should be completed by the end of December. And work will be undertaken to ensure the Health Board has a campaign on violence and aggression, especially over December, and highlighting what can happen in those incidents and bringing them to the fore. And it would be helpful for board members to receive update training around contest and prevent in the next year.
Okay, we've had a bit of a list outside of December. There's training that board members need to undertake, so we'll be taking that forward next year.
Great. Thank you. Thank you. And thank you, Anne, for taking over chairing this committee very ably.
Thank you.
Okay, so now move us on to 8.5, which is the joint the committee update reports. Jo, is there anything to
Yeah, so there
highlight?
are some matters, Chair, that the board will need to formally ratify, particularly from we did hold an in-committee board in relation to the financial position, and the board agreed to make a change to that. Obviously, you can't make a decision in committee, so the board need to ratify that in the public domain. And the other matter we considered was in relation to land, some commercially sensitive information. But also, we do need to ask you to approve the new members to the Health Care Professionals Forum as well, Chair.
Yeah. Okay, so we're content to approve those recommendations, changes. Thank you very much.
Can I ask one question on the update from the Staff Partnership Forum. We talked about industrial action, conscious that in England there's been an offer accepted or about to be accepted by the consultants. Just wondering if we have an update on what kind of situation is the industrial action.
Yeah, there's no change in the position at the moment, so conversations are still continuing between NHS employers who are leading on behalf of Wales and the BMA. So at the minute, our ballot still is scheduled to close on the 18th of December, with potential action commencing on the 8th of January. If it's endorsed.
We have a group that is planning on the response to potential industrial actions.
Chair, tomorrow we will be going straight after the main committee into the trustee meeting, because there are two matters from this week's Charitable Funds Committee that the trustee needs to approve, Chair.
Okay, thank you. Then we have item 9.1, which is the joint committee. Steve?
Happy to take any questions.
Thank you. Any questions? No? Thank you. And then we have the statutory partnership update. Jill, anything to highlight?
Take any questions.
Okay, thank you. And then we have the board annual work plan, which, as we know, will be updated after today. And the date and time of the next meeting is the 25th of January. However, we do have a special board meeting which has been scheduled, and you have received this information on the 14th of December. The only change to the published programme is we're going to do the board meeting first at 9 o'clock, and then we'll move into the board seminar, which will include the workshop on the financial plan. So the information on that will be coming out in advance of that meeting. So before we move into committee, I'm going to ask us to move into the meeting of the corporate trustees. So I'm just get to my this very old school. They're snowing all the papers. Here we are. Okay, so we have apologies now from Chantal. So I think that's all the apologies. Any declarations of interest? No? Okay, thank you. So if we can move into the main session, which is the ratification of the charitable fund requests. You're still here, Mandy? Are you going to do that?
Yes, I'm still here. So this is just to identify that we have, in fact, in our most recent meeting, which was earlier this week, discussed the Brombrice Hospital Chemotherapy Day Unit refurbishment, and the fact that the funds, the corporate trustee is requested to ratify the request for charitable funds expenditure of 912,989 pounds. From the I couldn't find the word for a minute, from the Brombrice Chemotherapy Appeal Fund for the capital scheme for the new Brombrice Hospital Chemotherapy Day Unit. We did seek confirmation that that funding would not transfer until the work was, it'll go in phases so that the work can, they'll call down the money as and when is required to the value of that sum. And then the second paper that we received, and it only came this week, so this really is hot off the press. We agreed to support the purchase of the neonatal ventilators. We did have quite a conversation about this and whether in fact this was something that needed to be considered through core revenue funding, or whether this was something that, because of the consequences of not being able to replace the neonatal ventilators and align the standard with, so there is consistency across the organisation, that it would be appropriate to for charitable funds to support this request of 120,727 and 72 pence. So the reason for this primarily was to, apart from quality safety reasons, to make sure that we have consistency of equipment. It was so that patients, i.e. young babies and their parents, do not have to travel excessive distances, particularly
into England because of the neonatal situation, the need for ventilators. So it was felt that that was for the benefit directly of patients, patient care and family experience. So it's really just to ask that the corporate trustee ratify both of those decisions.
Thank you. Any questions?
Chair, as chair of the charitable funds, I can confirm that there was a very robust discussion in regards both, but especially the neonatal ventilators. And as a group, we strongly agreed with giving this consideration and recommendation to you.
Okay, so Lee?
Yeah, just a minor point in the bronchitis chemotherapy, it talks about the scheme delegation. I don't think that's correct. So I think we just go back to that, correct, but not.
Sorry, which bit here?
There's the scheme delegation there, level 1 to 4. I think we'll correct the record.
Okay, that doesn't alter the request.
I don't think it alters
No,
the request, it's just the making sure that it goes through the right delegation.
So we'll make sure that's corrected for the minutes. Okay, so our trustee.
Yeah, we need to pick that up.
Yeah. Okay. Thank you, Lee.
Thank you.
So, okay. So, are the trustees content to ratify the release of these two sums? Yes. Yeah. Thank you very much. Okay. That concludes the main public board and also the trustee meeting. So I will now ask.
Business. It's a very
Oh, sorry.
But very minor matter under any other business. For anybody that would like to purchase charitable Christmas cards, they are still available for purchase at, I think as I'm doing sales person's job today, at a pack of 10 for £2.50. They all go to a worthy cause.
Yes.
So please could you support the charity to continue to be able to make good allocations.
Yes, thank you. You did remind me about that.
Thank you. Sorry.
Thank you. Okay, that does end the meeting, so we can just wait for Karen to disconnect.